A very good evening to everyone. My name is Abhishek and I represent Dr. Reddy's. I think not take much time. I just wanted to thank Dr. Agrawal sir for all the guidance and this 5-day meeting. Yesterday we had the multiple myeloma. Today we have leukemia, and also thankful to Dr. Chandi sir for being there as a chief guest. That is it for my side, sir. Over to Agrawal sir.
Thank you, Abhishek. So, Mumbai Hematology Group, together with Dr. Reddy's, bring to you this 5-day webinar, Year in Review, Hematology 2021. As you witnessed yesterday, what we are doing is to cover the presentations or publications that took place in the field of hematology during 2021, the last 10 months. I am grateful to Dr. Reddy's because this idea was conceived by them and they approached Mumbai Hematology Group to execute it. Today is the day for chronic myeloid leukemia, and one has to acknowledge that from the Reddy's house, we have an important molecule in the form of dasatinib in various strengths 50, 70, and 100 by name Invista. All our webinars for last 1 year, 8 months are being managed beautifully by Mice Ideas, and I'm grateful to them for the same. So this is day 2. Our chief guest of the day is none other than Dr. Maman Chandi, and I'm indeed grateful to him for having accepted our invitation to inaugurate day 2 of this webinar. Dr. Maman Chandi does not require any introduction to anybody who is listening today, and I'm just completing the formalities. He's director of Tata Medical Center, Kolkata. After his post-graduation in medicine in 1978 from CMC Vellore, specialized in hematology from Sydney, Australia in 1985. He's fellow of Royal Australasian College of Physicians and the fellow of Royal College of Pathologists of Australasia. Subsequently, he was professor, Department of Hematology at CMC Vellore until 2010, when he retired and became the director of TMC Kolkata. He's in that position till today. During his tenure at CMC Vellore, he was head Department of Hematology for 2 decades, 1987 to 2007. He was also Associate Director HRD CMCH Vellore from 2000 to 2004. He was instrumental in developing the best department of hematology at CMC Vellore, followed by equally good department at TMC Kolkata. He was also instrumental in developing various branches of hematology in his department at CMC, that is bone marrow transplantation, molecular hematology, coagulation and thrombosis lab, just to name a few. His was the first department to be recognized for DM in hematology, and we know what contribution the products from that department have in this country today. He has been the chairman for Task Force on Human Genetics and Genome Analysis, Department of Biotechnology, Government of India, Ministry of Science and Technology, member Scientific Advisory Committee, Basic Medical Sciences Division, ICMR, member Scientific Advisory Committee, NIH, member Scientific Advisory Committee, TMH. Under his guidance, many research projects have been executed. Some of these include evaluation of the National Nutritional Anemia Prophylaxis Program by ICMR way back in 1984, field supplementation trial by ICMR 1984, collaborative study on hemophilia ICMR 1985, evaluation of immunosuppression with anti-T cell monoclonal antibody in the treatment of severe aplastic anemia ICMR 1987, molecular genetics of thalassemia, hereditary bleeding disorders, and leukemia, Department of Biotechnology 2004. It's my pleasure to request the respected Dr. Maman Chandi to inaugurate our day 2 of this webinar and bless us with some words of wisdom. Thank you.
Thank you very much, Dr. Agarwal. As I said before, I really am amazed at your ability to organize so much of educational activity for hematologists in this country. I think we all have to be grateful for the fact that you bring latest information in a very interesting way to this country and all those who are interested in the discipline of hematology. So thank you very much, and our respect and regards to you for this singular contribution. Today, our brief is to discuss chronic myeloid leukemia. In 1960, David Hungerford and Peter Knowles, in a one-paragraph paper in Science, announced to the world the discovery of the Philadelphia chromosome. This discovery was epoch-making because it was the first non-random genetic change that was ever described in a human malignancy. So it is truly the beginning of the molecular era for chronic myeloid leukemia. And we haven't looked back since. Janet Rowley told us that this was not just a deletion of chromosome 22, but that it was a reciprocal translocation between chromosome 9 and 22. And this was followed by the discovery of the consequence of this translocation, which was the unregulated increase in a tyrosine kinase, which resulted in a huge number of downstream events, which resulted in the proliferation of the myeloid cells. This discovery has changed the way we approach diagnosis, monitoring, and treatment of this disease. We no longer do a bone marrow diagnosis. This is debatable, but I don't. We rely on an RT and an RQ-PCR, and that's how we track this disease molecularly. If there is failure to respond, then we do a mutation and see what's happening. The introduction of the imatinib into the treatment of chronic myeloid leukemia has resulted in a dramatic change. I have grown up in the era when the only drug available was busulfan. And you saw patients who were pigmented without the quality of life that they deserve. Imatinib has changed all that. Today, we have patients who are living more than 10 years with good quality of life, doing everything they want to do, and that's a revolution in molecular medicine. Of course, the disease has its own biology where new mutations arise, but science comes up with new drugs, and now we have, apart from drugs which attack the tyrosine kinase ATP binding domain, we have drugs which bind the myristoyl binding site. And each year we see new developments. And what is really amazing is that we can stop treatment in a proportion of patients who remain in molecular remission. So in fact, in my own lifetime, and in many of those like Dr. Agarwal, we have witnessed a tremendous change in the way we diagnose chronic myeloid leukemia. So today is devoted to this topic, and I'll hand you back to Dr. Agarwal.
Thank you so much, sir. Dr. Mammon, in 2 minutes, has summarized what has happened in this field for last 50 years, maybe even 60 years. And I think we have very little left to discuss for next 3 hours. This was such a beautiful summary that you narrated. So carefully selected the words, the sentences, the history, the present, and the future. Hats off to you. That's an art which we have learned from you. And when you say that, Dr. Agarwal, how do you do all this teaching activity? I feel like sharing one little thing. When I was a resident in hematology, there were no computers. The books were not easily available because they were expensive. What was available in the library was obsolete. And if there were, they were not in the field of hematology. And when you went to the pundits to ask something, they didn't want to part with the knowledge. They made you come 10 times and then parted with one sentence, which was you felt you already knew. This was such an impact on me that in this country, with scarce resources of books and journals and the power of money to buy them and read them, there are people who don't want to share the knowledge. And that was the genesis of our first CME in hematology. With those who were willing to part knowledge, they became the faculty, and then there was no going back. So that's a little history behind what happened. Thank you so much for being with us, inaugurating this day, and we are extremely grateful to you. Whenever you are there, the whole story becomes very different. The life comes into the webinar, and I'm grateful to you. We move on to the second part of today's session, and that is related to our first lecture. So those of you who have logged in a bit late, Dr. Maman Chandi just inaugurated our day 2 of this webinar, which is named Year in Review Hematology 2021, a concept which was conceived by Dr. Reddy's and implemented by Mumbai Hematology Group. Dr. Reddy's house has a molecule which is useful in the treatment of CML, dasatinib in various strengths by the name Invista. We have 4 parts of this scientific educational activity, the first of which is the lecture. And the first lecture is, and the only lecture of today is, navigating treatment options for CML across the disease continuum. And who else can do a talk on this except the man, Dr. Hemant Malhotra, Director, Oncology Services, Siram Cancer and Super Specialty Center, Jaipur, Professor and Head Department of Medical Oncology, Mahatma Gandhi Medical College Hospital, Mahatma Gandhi University of Medical Sciences and Technology, Jaipur. Most of you know, but I may just repeat that I think it was 2019 in ASH when he spoke about the care of CML in the developing world in the education session. A rare privilege for an Indian to do that. And you have been shining the torch of India in the field of CML in various ways. So over to him.
Am I audible and visible, sir?
Yes.
So my most sincere thanks to Dr. Agarwal and of course Dr. Maman.
Hemant, I think you'll have to put off your fan again today.
Okay, I'll do that, sir. 1 second.
Yeah. Sorry for that.
Are my slides visible, sir?
Yes. No, not yet.
Now, sir?
Not yet.
Is my presentation visible?
Not yet.
So I did do not visible, sir. Hello.
I can't see.
Not visible, sir.
Nirav, can you see it?
No, I cannot see the screen.
No, we can't see it. Yes.
So let me do it one more time, sir. Is it better now, sir?
Yes, sir. Yes, put it on a full screen, sir.
Yeah, now it is full screen.
Yes, good to go, sir.
Okay, great. Thank you very much. So it's really truly wonderful, and you know it's a tough job to follow speakers like Dr. Maman Chandi and Dr. M.B. Agarwal. And you know we've grown up in hematology, looking up to these people. But I'll try and do my best. And the topic which Dr. Agarwal has given me is navigating treatment across the disease continuum. So my greetings to you from my hospital and my cancer center. And my most sincere thanks to this great man who has revolutionized hematology teaching and training in our country. Thank you very much, Dr. Agarwal, for this opportunity and for the chance to speak to all of you regarding, you know, the topic which I like very much. I don't know too much about it, but I like it really, truly much. So, ladies and gentlemen, as Dr. Maman indicated to you during his very concise and crisp introduction, that across the world, whether you take United States or the Dutch in Europe or Italy through the GIMEMA or the German CML study group, across the world, the the survival of patients with CML has been gradually increasing. This is what it was in the 60s. This is what Dr. Maman was referring to when Dr. Agarwal and Dr. Maman were treating CMLs with hydroxyurea and sometimes interferon. And this is what it is today. We can expect more than 95% of our patients to survive for more than 10 years. And now, as I'll show you just now, the survival of patients taking the tyrosine kinase inhibitors has become now equal to the people in the general population. And this is a publication way back in 2016, again highlighting to us that life expectancy of patients with CML approaches the life expectancy of the general population. And whether the patient is a male or a female, 55 years of age, or 75 years of age, or 85 years of age, this dotted line is the life expectancy of the general population. And this in post-2010 is the survival of patients with CML. You can see that the curves are overlapping. So that is the kind of achievements we've made with tyrosine kinase inhibitors. So just to summarize, we've now approached normal life expectancy in our patients with CML. A very high percentage of our patients are reaching deep molecular response. And a relatively new perspective, which Dr. Chandy again highlighted, the concept of treatment-free remission, meaning lifelong treatment not being necessary for all patients, has emerged in the past decade, and it may be possible for about 20 to 30% of all patients of CML. However, some challenges remain, and the challenges primarily include how to manage patients with the blast crisis, how to manage the small number of patients who have primary resistance to tyrosine kinase inhibitors, to give a good chance to patients who have acquired resistance. Once the patient plateaus, the BCR-ABL is not going down anymore, it is stuck, say around 1%. What do you do for those patients? And the patients are in deep molecular response, but a treatment-free attempt has not been successful. And certain therapies are being devised and have been devised. Allogenic stem cell transplantation enhance your kinase inhibition by more powerful agents like asciminib. We'll talk about this subsequently also. You target a second pathway either through venetoclax or pioglitazone or ruxolitinib, or you add to the immune-mediated killing of CML stem cells by adding interferon or lenalidomide, or one of the checkpoint inhibitors, or find targeted monoclonal antibodies, or even think of CAR T cells and chronic myeloid leukemia. So this is, I think, the clinical continuum, or what I think the important part of the clinical continuum of CML. The newly diagnosed patient with chronic phase, the standard risk patient, and the high risk patient. The CML-CP patient who's had suboptimal response or who has molecular relapse or is intolerable to the first line treatment, whatever you give him. The CML-CP patients who has the T315I mutation, the CML patient who presents in the accelerated phase, and the patient of CML who presents either in the blastic phase or sometimes during the treatment goes into blast crisis, either myeloid or lymphoid. So we'll see if we can address these one by one and kind of give a message to our younger colleagues. So let's first talk about how do you approach the newly diagnosed CML-CP patient, both standard risk and high risk. So we know these magic bullets. Dr. Maman mentioned about these magic bullets, and I was along with Dr. Agarwal and Dr. Chandy and hematologists and oncologists of that era, fortunate enough to witness this miracle, the arrival of imatinib in the early 2000s, then the availability of nilotinib, dasatinib, bosutinib, and at least these two second-generation tyrosine kinase inhibitors, dasatinib and bosutinib, are now available as generic in our country. Then the third generation TKI, ponatinib, which is available in the West, but unfortunately not freely available in our country. and the up and coming fourth generation agent, asciminib. The second generation tyrosine kinase inhibitors have been compared head to head with imatinib with the newly diagnosed patients of CML-CP. This was the first line dasatinib study, the Decision study. And here, 5-year results, you can see the blue curves are major molecular response with dasatinib compared to the yellow curves, which is the major molecular response with imatinib. 76% versus 64%, a significant difference. 0.0022 is the p-value. And when you talk of deep molecular response, MR 4.5, where we want to be when we think of treatment-free remission, again, you can see a significant difference, 42% versus 33% between dasatinib and imatinib. If you move on to nilotinib, again, the eNEST-ND trial was the phase 3 randomized head-to-head comparison between nilotinib and imatinib. 2 doses were used, nilotinib 300 BD and 400 BD. And again, you can see the curves here, the 2 doses of nilotinib on top over here, and the red curve is of imatinib. And if we talk of MR 4.5, this is 63 and 62% versus 45% at 10 years. And this is a hugely significant difference. Now, if you look at the first line use of nilotinib and look at patients who are less than 10% at 3 months, regardless of so-called score, you can see that there is a much bigger difference in patients who have high risk disease as compared to patients who have low risk disease. So the use of the second generation tyrosine kinase inhibitors, particularly in patients who have high risk chronic myeloid leukemia or high burden disease, there is a significant difference, and the difference is much more as compared to patients who have low risk. Now, again, if you talk about high SOCAL risk patients, the 5-year estimates, again, a pooled analysis of the eNEST-ND 60-year update, you can see very clearly a very significant difference. The dark bars are nilotinib and the light bars are, the dark bars are BCR-ABL less than 1% and the light bars are BCR-ABL 10%. You can see a big difference across patients who have high SOCAL risk. Similarly, we have a B4 study which compared bosutinib versus imatinib in the newly diagnosed patients. And again, if you look at major molecular response, or you look at MR4 or MR4.5, bosutinib does significantly better vis-a-vis imatinib. And here are the 3 studies with you compared head-to-head. Cumulative major molecular response, imatinib versus dasatinib, 64-75, nilotinib 70-77, bosutinib 59% versus 69%. But at about 5 or 10 years follow-up with various studies, a shorter follow-up with the bosutinib study, the overall survival remains in excess of 90%, but not statistically significantly different. So if you use a second generation TKI, there is a gain in all parameters of molecular response. This is cytogenetic response, 15% gain with nilotinib, 12% gain with dasatinib. Major molecular response at 12 months, almost a 30% gain. A major molecular response at 5 years, a 20% gain, and complete or deep molecular response, as we call it now, at 5 months, 23% advantage with nilotinib and 10 or 15% advantage with dasatinib. However, the overall survival at 5 years is not statistically different, even though numerically it is a little better, but this does not indicate statistical difference. So again, the key predictors of response, the most important thing which has come up is high SOCAL risk, whether you talk of cytogenetic response or PFS or overall survival. The blue curves are curves of low risk disease and the lower curves are curves of high risk disease. This again, I think we've already covered. The biggest difference biggest difference in MR 4.5 is in patients who have high risk focal disease when you use second generation TKI versus the first generation TKI. So I think we've already shown this to you, and this is the NCCN guidelines for you, the latest version. So before you decide the treatment of a patient, you must consider the patient's comorbidity, the toxicity profile of the TKI, the drug interaction, and of course the patient preferences. And for patients who have low risk disease, you have a choice of the first generation TKI, which still remains category 1 in low risk disease, or you have a choice of any one of the 3 second generation TKIs, either bosutinib or dasatinib or nilotinib. And when you move to the high risk disease, then the preferred regime as per the NCCN is one of the second generation TKIs, either bosutinib or dasatinib or nilotinib. However, in the other recommended regimes, you have imatinib also. So clearly for patients who have high focal risk, the guidelines are now also moving towards using the second generation TKI. Because these drugs have to be taken for several years, even if you are contemplating TFR, sometimes they have to be taken for a life. You have to understand the toxicities, the long-term toxicities of the 4 agents which are approved in the first line. Imatinib, you know, it is the most extensively studied. Hematological toxicity is not very much. Non-hematological toxicities, you know, edema, GI effects, decreased phosphates, arthralgias and myalgias. And there is some little bit of concern about toxicity on the cardiac function and late renal effects. So there's a gradual increase in serum creatinine over a period of time. So this has to be considered. Nilotinib, we know the problem is that it has to be taken twice a day and it has to be taken before meals. It does have non-hematological toxicities, which includes increased lipase, bilirubin, cholesterol, glucose. There is a black box warning regarding patients with QT prolongation. And the thing which is of major concern to us, particularly for the younger patients, is the gradually increasing mounting incidence of vascular events. Dasatinib, again, the most common non-hematological toxicities are pleural and pericardial effusions happening in almost about 1/5 of patients. And the more serious late toxicities are pulmonary arterial hypertensions, which has to be watched for. Bosutinib, again, a relatively shorter period of study. Main problems are diarrhea and hepatotoxicity. They have to be monitored in the early months. And late toxicities, again, are not very much known just now, but emerging mild effects on the GFR are coming up. Ponatinib is not available in our country and it's not approved for first line, so we'll not talk about that. So if we move to the second issue, what about patients of CML, CP who have either suboptimal response or have a molecular relapse or have intolerability to first line treatment? Early response milestones are pretty well known to you. At 3 months, what should happen? At 6 months, what should happen? At 12 months, what should happen? You know, across the NCCN guidelines and ELN guidelines has been laid down pretty clearly. So this has made things quite easy for the clinician. If the patient is in the yellow bar, say, for example, the patient does not achieve a BCR-ABL less than 10 in the first 3 months, then you need to keep your antennas up. You need to counsel the patient. And if the patient still doesn't have less than 10 BCR-ABL at 6 months, you need to, you know, do something else, change the TKI. So one most important take-home message for my younger colleagues is that if there is at the first evidence of suboptimal response or molecular relapse, please check the drug compliance. Non-compliance to drugs, even in the best, most educated countries, is as high as 15 to 20%, and it may be as high as 30 to 40% in our country. So that is a very simple way of making sure that you don't need to change your drug. Then selection of therapy after first line, it depends on several factors. The first factor is what agent you've used in the first line. If you've used imatinib, then you could use any one of the second generation TKIs. If you've used one of the second generation TKIs, of course, you can't go back to imatinib because it is a lot less potent than any one of these agents. You could use the other TKI, or you could think of the third generation TKIs. And then similarly, for the third line, you have the third generation TKIs, ponatinib, which again is difficult to procure in our country. And you should also start thinking of stem cell transplantation. So choice of the second generation agent depends upon, as I said, what first line agent has been used, what comorbidities the patient has, the kinase mutation analysis, then the lifestyle of the patient's choice, and the patient's affordability. And you have certain mutations in the kinase domain, which, and if any one of these are present, then bosutinib is not likely to work. If any one of these are present, then dasatinib is not a good choice. And if any one of these are present, then nilotinib is not a good choice. So there are some tools now which could help you to predict the response to the second generation TKIs. This is a publication from the Hammersmith group, and they have used these three criteria: best cytogenetic response, Sokal risk group, and whether the patient had neutropenia during first line treatment or not. And using these three, you can get to a score which will tell you very clearly that this is a good risk patient and this is a poor risk patient. The good risk patients have an excellent chance of responding to a second generation TKI as converse to the poor risk patients. Similarly, a score has been developed from the MD Anderson group, and this takes into factor two considerations: lack of any cytogenetic response to previous treatment and ECOG performance status. And then again, it can identify poor risk patients and good risk patients, and you can kind of predict the proportion of patients responding to your second line treatment. So now let's move to the third point in our clinical continuum: the patients of chronic phase chronic myeloid leukemia who have the T315I mutation. And this is the commonest mutation occurring in about a quarter of patients. It confers resistance to the first generation and the second generation TKIs, but it is sensitive to the third generation TKI and also to asciminib and omocitaxin. And these drugs are usually used to get the patient and used as a bridge to allogeneic stem cell transplantation. So this is the imatinib resistance mutation landscape for you. And as I said, the T315I is a P-loop mutation, and it is the commonest amongst all the various mutations which have been seen and described. And again, nilotinib, imatinib, nilotinib, dasatinib, bosutinib, all are insensitive to this mutation. However, ponatinib and the newer TKIs are sensitive to this mutation. There's been some very exciting data with ponatinib coming up and being published regularly. And just to show you a quick snapshot of the 5-year outcomes with ponatinib in patients of CML who have been exposed to prior TKIs, whether the patient has had 1 TKI or 2 TKI or 3 TKI or even 4 TKIs, almost a significant number of them can develop a cytogenetic response. A significant number can have major molecular response, and about a quarter of them can have deep molecular response, and with a nice, healthy, more than 75% 5-year possibility. Then asciminib is the new kid on the block. This is a unique agent which has been developed in the laboratory. It has a different mechanism of action. It is known as the first STAMP inhibitor, STAMP standing for specifically targeting the specifically targeting the ABL1 myocytol pocket. And this is the mechanism of action of this agent. The myocytol terminus, it acts like the pin in the grenade. When the pin is inserted, the gene is inactive. And once the pin is taken out, which happens in chronic myeloid leukemia, the grenade becomes active, explodes, and produces the full-blown syndrome of chronic myeloid leukemia. And this agent can again, the asciminib can again act as a pin and get the grenade or the gene into a inactive state. This was the first publication regarding this new agent, December 12, 2019, the phase 1 study of asciminib in chronic myeloid leukemia. And there was a oral presentation, an abstract in ASH 2020, in which they picked out the T315I mutation patients. And this is the cohort which they presented in the ASH oral presentation. So I'll just highlight to you this particular cohort. There were 52 patients, almost half of them had more than 3 tyrosine kinase inhibitor exposure. About 2/3 of them had exposure to ponatinib, and even in this heavily pretreated group, there was a good control of the disease, and almost 50% of the patients did manage to have major molecular response. So this agent, asciminib, even in our worst mutation, is an active agent. And here is the cumulative incidence of major molecular response. Of course, the response is much more in ponatinib naive patients as compared to ponatinib treated patients. But even in the ponatinib treated patients, about 28% can achieve a major molecular response. Toxicities are not very frequent, very few grade 3 and grade 4 toxicities, predominantly being diarrhea, nausea, rash, vomiting, and increased hepatic enzymes. So this drug does appear to be a good drug. Several future studies are being planned with clinical trials are being planned with asciminib. One particularly exciting concept with asciminib is that it can be combined with the other tyrosine kinase inhibitors. And these are, again, extremely exciting combinations. And let's hope what future place asciminib can get in the treatment of CML. So now to talk last few slides on the accelerated phase, blastic phase of CML. We are pretty aware that patients who have accelerated phase have a much poorer survival as compared to patients who are in the chronic phase. Even though we have made significant progress, even in this bad prognostic CML setting, like we have increased our 5-year survival from a dismal 20% to about 70% now. This is statistically significant. And again, in the blastic phase, the things are even worse, even more dismal. But there has been a gradual improvement over the years, even in the blastic phase. And the current recommendation of treatment for patients who present in the accelerated phase, we have to think of 2nd generation or 3rd generation tyrosine kinase right up front. Imatinib doesn't have much role over here. So you need your most powerful agents to control these diseases. And you have to get ready and do the workup for a bone marrow transplant. And for a patient who's not doing well, who does not get into major molecular response, a quick consideration of allogenic transplant must be kept in mind. Patients who have lymphoid blast crisis are usually treated with a combination of TKI with an ALL type induction chemotherapy. And similarly, for patients who have myeloid blast crisis, AML type induction treatment with a TKI, these are the ways to move forward. All these patients, once a disease control has happened, they must have an allogenic stem cell transplant, and only then they can be expected to have some kind of a long disease-free survival. So I think in the future, what we are looking at is that we are, of course, going to do the bioassay and the molecular dynamic driven assessment of the response to the TKI. And this will be at the diagnosis, we will do a bioassay and then decide according to the projections of this bioassay whether the patient needs imatinib. And this will be the majority of patients. You can see the weight of this arrow over here. There will be a minority of patients who right up front, we will be able to identify that they need a 2nd or 3rd generation TKI right up front, right at diagnosis. And there might be a 3rd group of patients, much smaller, who are destined to primary TKI resistance. We will think of and develop some experimental therapies. And then we will move on to then looking at molecular dynamics of the response, and then decide if the response is optimal, then we continue the same treatment. If it is not optimal, then we switch. or we think of a combination. And once a sustained deep molecular response has been achieved, we could think of stopping the drug for a select number of patients, or giving the TKI for a few more years, and then thinking of a TFR experiment, or for a group of patients to intensify treatment more. These bioassays will determine these choice of these treatments in the future. So if I were to summarize last two slides, life expectancy of CML-CP patients is now approaching that of age-sex matched control of persons without CML. And this is only possible if expert management is provided to a patient. So my appeal to my younger colleagues is that if you cannot provide expert management, please send that patient to a person who can. Otherwise, you will be doing a big disservice to a potentially curable cancer patient. For the newly diagnosed patients of CML-CP, today several options of treatment are available with the availability of generic dasatinib and bosutinib. And once more, I salute our Indian pharmaceutical industry, including DRL, for making these two agents available to us. So they are becoming the second generation TKIs are becoming an option in the first line treatment, and of course in the second line treatment, which is within reach of many patients. And it should definitely be considered for patients who have high disease burden, who are young, who are desirous of pregnancy. The choice of the TKI for the newly diagnosed patients in the first line and also in the second line will of course also depend on costs, comorbidities, convenience, and toxicities. The next generation drugs like asciminib are effective in the third and the fourth line. The role in the first line is being debated and very carefully considered. And these drugs also work in the T315I mutation, and further trials are very eagerly awaited. And we would implore Novartis to consider some of the asciminib trials in our country also. Allogenic stem cell transplant still remains a curative option for some patients, even though it is relegated sometimes to second line or third line or even fourth line. TFR is a reality and should be the goal of treatment, at least for all the patients who are young. We don't want a 20 or a 30-year-old young patient with CML, either male or female, to take the TKI for 15, 20 years and then have long-term toxicities. Of course, TFR should be considered for young female patients who are desirous of having a child. So, ladies and gentlemen, the prevalence of CML with the success which we have achieved is expected to increase hugely. So we need to gear up to tackle these large number of patients. We need guidelines and consensus statements from experts like Dr. Maman Chandy and Dr. M.B. Agarwal, which are applicable for our patients. We also need free subsidized access to the second generation, third generation TKIs. We are fortunate to start to have generic versions now. We need improved availability and access to allogenic stem cell transplantation, and we need improved access to molecular testing. And the Max Foundation model, maybe again, that is something which should be thought of. With that, ladies and gentlemen, I'd like to conclude my presentation, and I'd like to thank you very much for this opportunity. And I will stop sharing my slides now.
Thank you, Professor Hemant, for that lovely talk. Very comprehensive. You covered everything right up to date. There are some questions in the question box for you. If a patient develops marrow toxicity in the form of severe thrombocytopenia or leukopenia on the lowest effective dose of either of the TKIs, and the patient is transplant ineligible, how do you manage these patients?
So there are pretty clear guidelines for all the tyrosine kinase inhibitors as to how to manage when to stop the TKI when there is a bone marrow suppression. And all of us have come across this situation when rarely the patient has a lot of difficulty in tolerating the standard dose of the TKI. So I may tell you that amongst the 3 TKIs available, 4 TKIs available to us, nilotinib is the least bone marrow toxic. We unfortunately don't have on a commercial level ways and means to estimate the blood levels. So possibly these patients have some mechanism by which they metabolize these drugs slowly. So the minimal possible dose, it may be 1/4 of the standard dose, may be tried in these patients.
Thank you. Another question is, what is your indication for doing a bone marrow upfront in a newly diagnosed CML chronic phase patient?
So I don't have any indication of doing a bone marrow transplant upfront. An allogeneic transplant.
Bone marrow examination.
Bone marrow, I do it in all patients because I feel that a cytogenetic analysis at diagnosis is important, and it is important to determine additional chromosomal abnormalities. And if a patient does have any one of these extra chromosomal abnormalities, which are pretty well described, then that patient automatically becomes high risk, and then that patient should be treated with the second generation more potent tyrosine kinase inhibitors, and should be monitored a lot more carefully than a patient who has only the standard 922 translocation. So I do advocate at diagnosis and not after that, unless there is disease progression.
Thank you. The other question is there a patient profile where you will go to a higher dose of imatinib like 600, 800, rather than changing to the second generation TKI once the 400 fails?
So all of us who have been treating CMLs for a long time in our country and have been associated with the GPAP program have faced this dilemma, because the second generation TKIs were not available in the GPAP program or difficult to get in the GPAP program. But the program did permit an escalation to 600 milligrams, 800 milligrams, and we've all done that, and we've had our share of successes. So if you look at the numbers and the percentages in literature, about 10 to 15% of patients can be expected to go into a deep molecular response or achieve a major molecular response with increased dose of imatinib. So that certainly for the non-affording patient is worth a try.
The last question is there a patient profile where you prefer nilotinib as the first line?
So again, as we discussed earlier, the treatment choice depends on a lot of factors. First and foremost is economics in our country. It is the lifestyle of the patient. So what I would say that if you have an agent, if you have a patient who has high risk disease, then he becomes ineligible or not a candidate for imatinib. Who has significant pulmonary disease, he becomes a relative contraindication to dasatinib. And if he has, say, irritable bowel syndrome or one of the inflammatory bowel diseases, he automatically becomes ineligible for bosutinib. That would be the right candidate for nilotinib. So you take all these factors into consideration when you decide.
Thank you, Professor Hemant. That's all what we could accommodate in the time available to us. Grateful to you for this wonderful contribution and educating our colleagues and students. Thank you.
Thank you very much. Obliged.
So with this, we move on to the part 2 of our education session. Those of you who have joined late, this particular 5 days webinar is the idea conceived by Dr. Reddy's, executed by Mumbai Hematology Group, and it has been called Year in Review Hematology 2021, as it covers the presentations and publications which have taken place in last 10 months of year 2021. The part 2 of this particular webinar today, and before that, I must tell you that from the house of Dr. Reddy's, we have dasatinib in various strengths like 50, 70, and 100 under the name Invista. And Dr. Hemant very rightly and nicely discussed the role of dasatinib in the treatment of CML. Part 2 of this webinar is a panel discussion, the subject of which is practicing treatment-free remission in India. We have moderator, Professor Sharat Damodar. He is clinical director MSMC, Senior Consultant Hematologist and Head of the Hematology and Transplant Unit at Majumdar Shah Medical Center, Narayan Health City, Bangalore. And the panelists, we have Galaxy of Stars with us, Dr. Ramaswamy from Esther MedCity, Kochi, Dr. Sandeep Shah from GCRI and Vedanta Institute of Medical Science, Ahmedabad, Dr. Aditya Murli from Esther CMI Hospital, Bangalore, Dr. Lalit Mohan Sharma from Sri Ram Cancer Center and Mahatma Gandhi Medical College and Hospital, Jaipur, Dr. Dilip Charles from Esther MedCity, Kochi, Dr. Mobin Paul from Rajagiri Hospital, Kochi, Dr. Ankit Rayani from Cure Hematology Oncology Clinic, Ahmedabad, Dr. Vikas Goyal from Sanjeevan CBCC USA Cancer Hospital, Raipur, Chhattisgarh. So over to Professor Sharad Damodar.
Thank you, sir. Just to continue where sir left, I think it's great that we're having a wonderful week of all these educative for that, to discuss this hot burning topic of treatment-free remission, which we think is certainly relevant. So I would certainly get more opinions in the form of the panel discussion, which is planned. And that's what we're planning to do over the next 15-20 minutes of discussion. So just to kind of put things in perspective, the panel has already been introduced by Professor Agarwal. I'll just quickly list out their names again. So all of them have joined. We've got Dr. Ramaswamy, Dr. Sandeep Shah, Dr. Aditya Murli, Dr. Lalit Mohan Sharma, Dr. Deepak Charles, Dr. Mobin Paul, Dr. Ankit Rayani, and Dr. Vikas Goyal. So to put things in perspective on the topic of TFR, the ELN guidelines are there as a publication, the 2020 recommendation, that's the most recent one, on where, you would start thinking of it, what is your mandatory requirement, and what is kind of the optimal setting to look at, practicing this. And clearly you're looking at patients who are in the first chronic phase. You really don't have data for anything beyond this. You need a highly motivated patient. You need access to high quality PCRs, and then the frequency of monitoring. All this will be actually addressed by the panelists. And typically there are transcripts which are described, which are obviously easier to monitor, and accuracy of monitoring them, the duration of TKI therapy, depending on which one you've used, the duration of the molecular response, obviously no prior treatment failures. And then you reach optimal when you can actually start recommending it, when your duration of TKI therapy is at least more than 5 years, your DMRs are more than 3 years if it's MR4, a DMR of more than 2 years if it's MR 4.5. So I will just quickly run through some data which exists on the 3 TKIs which are most commonly used. So the first one is the INES top 192-week top-up result, which was recently published. And here they looked at the remission following, kind of given as a second-line setting here, after an initial trial of imatinib. And then they went on to a nice little algorithm, and once the criteria were fulfilled for stopping it, they were monitoring the RT-PCRs every 4 weeks initially, then 6 weekly, thereafter 12 weekly. And the gist of that result is here, that your TFS comes to about in that 50% range. So this is what we need to remember when we are looking at nilotinib. And then the ones who lost response, the good thing is that all of them, almost 90% of them quickly regained it. You can see here 98.9% regained MMR and about 92.3% regained an MR 4.5. So it's good to know that, because when you're telling this to a patient, these are things which will come up. And this update, which was the 192-week, kind of followed on the back of the 96-week update, where numbers changed from that 48.9% to about 48% in the second follow-up. Clearly, there are AEs described when you take away the drug. And this is an important thing for us to remember, that people, one is the psychological apprehension. Secondly, the issue of muscle fatigue, body aches, some of the skin changes which have been noted. So these are things which crop up in the patient's mind, and it's good for us to know that. Now, what about imatinib? So this is data on the stoppage of imatinib, because this is the other drug which I think a lot of us initially have used before the second generation TKIs were easily available. And the same kind of principles are followed here on how you do your assessments, wait for at least CMR beyond 2 years, and then you stop and then keep monitoring the RQ-PCR monthly. And here, if you look at this curve, it kind of plateaus at the 40% range. So this is what it is when you the kind of TFR you achieve when you're on imatinib. And the last drug, which is dasatinib, again on the back of initial imatinib therapy followed by dasatinib, they gave a consolidation phase and then picked the subset of patients where they could actually look at discontinuing. And this is the data which came out, that about 0.5% of patients you could actually take off completely off the drug and maintain them in a treatment-free remission. So that's the gist of it. And thereby these guidelines, which are initially published by Tim Hughes and team on which is the subset of patients where you can actually look at, was actually upscaled in the subsequent 2020 ELN-NET guidelines. One little update, that when we try to take off a drug, you have to look at it from the patient perspective and look at their needs. And sometimes there are psychological issues which come up when you're bringing this up. So this data, which was published recently in 2020, highlighted that about 56% of patients clearly expressed fear and anxiety during the topic of discontinuation. When treatment was restarted in about half of them, they still had that anxiety persisting about how they would respond the second time. And there was about 50% of patients who also had depression on having to restart. So that's the other side of it, So these are things we need to keep in mind when we are bringing this up. There's this component of fear, little anxiety, depression, and the musculoskeletal side effects which can pop up when you take off the drug. So with all this in mind, I will now go to my panelists and put them a kind of set of questions which I've kind of put into a little kind of survey kind of thing, ask them and then get their opinions and compare that and see what is the practice in our country from some of the senior physicians who are actually practicing treatment. So the first set of questions is to Dr. Ramaswamy. So Dr. Ramaswamy, I'll give you the first two, which is the drug of choice in low risk, so-called risk, drug of choice in high so-called risk. If you can answer them, and then we'll go on to the second set.
The drug of choice in the low so-called risk, as everybody is convinced with the historical experiences with the imatinib, irrespective of the age, can be considered. And of course, in the younger age patients, as our median disease onset in Indian perspective is 38 years, long way to go. So definitely you can consider the second generation TKI as the first line options because of the availability of the generic versions, and even with the study of DASAF 50, we can be considered, and of course bosutinib also, of course, little costlier than that. Come back to the choice of the high so-called risk CP, and definitely we all know that it is that Dr. Hemant has clearly in his slide shown that the benefit of the second generation TKI. I would like to go for the second generation TKI. Question is which is one is to be chosen based on the comorbidities, whether it's a lung or GI or a cardiac, diabetes, metabolic, liver, and based on that you decide on that. And along with that, you go ahead with the financial this one into the consideration, starting from DASAT to the bosutinib to the nilotinib, depends upon the availability, accessibility.
So Ramaswamy, in low risk, are you doing the second generation TKI or you're starting imatinib?
I am starting with the elderly patients. I will go for all the patients to take it for all the age group. First choice is going for the imatinib.
Okay.
Younger patients, giving the options for the TFR into the considerations. I will talk it even if it is a low risk patients. Options. First choice, imatinib.
Okay. Do you do a baseline quantitative BCR ABL?
No, I am not doing it, and even the NCCN or the ELN does not say this.
Right. What about baseline cytogenetics?
Definitely, we should do the bone marrow and also the base as Dr. Hemant mentions that ACA additional clonal evolution has to be seen.
So now the last part, are you already thinking of TFR in this young patient who's come to you, newly diagnosed CML, and kind of bringing that up even from the choice of drug perspective?
Yeah, definitely. I will have a detailed discussion. First, in the first visit itself, I'll talk in order to make the patient that disease maybe in a perspective of the curative to stop the medicines, in order to make that positive effect onto the patient, if not for the TFR purpose. And subsequently, as the disease is being monitored and making them to understand that probably every visit after the 3 months, based on how is the things going, we can advise for that. I will advise.
And thereby, on the back of that, would you also then consider offering the second generation TKI to that person just because you brought up the issue of TFR?
Absolutely. But the TFR is not meant that the TFR, even the low risk cases, we can go with the imatinib, but that also you can produce the TFR. It is a duration of the drug and also that deeper molecular remissions of the duration. Both these things also will, even though we know that second generation will have a faster major molecular remission, still can be considered with the imatinib also. So I will keep that options. Keeping that the TFR into the situation, I'll ask the patient to take a call with the help of my knowledge.
Okay, thanks, Ramaswamy. I'll come back again at the end after I get the other panelists' opinion so that we kind of come to some kind of consensus. Now I'll move to Dr. Sandeep Shah for his set of questions. So again, Dr. Sandeep, welcome. And I'll again start again with the same low so-called risk and high so-called risk choices before we move on to the second part. Dr. Sandeep.
Yeah, I will go straight away that for low so-called risk chronic phase, I will go for imatinib. Only those young patients and female patients who want pregnancy, I may discuss with them if TFR is their choice in future. Then I may start with second generation TKI even in low so-called risk patients. But otherwise, all other patients, it will be imatinib.
And in the high so-called risk, any specific choices for your
high so-called risk patients, young patients? I will usually start with nilotinib, and maybe there is a personal bias because I get a lot of pleural effusion with dasatinib, so maybe it's a personal bias. But I will start with nilotinib, and those patients who are elderly CML patients with some comorbidities, I will start with imatinib 600 milligram rather than putting them on dasatinib or nilotinib.
Right. I think that was a question which came up in the previous discussion, the option of a higher dose of imatinib, which I think you've just brought up from your own experience. And like you said, I think personal experiences do, affect your choice. If you've seen more effusions, probably you might want to go the other drug route. Which is fair, and that's the whole reason of having this panel discussion, to get experiences of people who've been treating CML. So, Dr. Sandeep, coming to the second part, do you do baseline cytogenetics, and do you ever repeat that again for whatever indication?
No, we do baseline cytogenetics in all patients, and then we monitor it with only quantitative RT-PCR, BCR-able, and usually we don't repeat cytogenetics.
Okay, unless there's disease progression, maybe.
Yeah.
And do you also do a baseline RT-PCR? Do you see any need for that at all, or is it just subsequent monitoring of RT-PCRs?
No, we do baseline RT-PCR now because this one log reduction, sometimes the baseline quantitative RT-PCR says only 30%, gives report of 30%. So in those patients, the one log reduction will be different from 100%. So now we are doing regularly quantitative baseline RQ-PCR.
Okay. It's good to hear that practice. So clearly that came in initially when the definition of MMR came in with the 3-log reduction, after which I think some of the labs set the benchmark of the 0.1% cutoff and variations on that. Right. So, so the last part is on the issue of TFR. Are you offering it upfront, or are you bringing that topic up only, say, 3 or 5 years down the line when you're absolutely sure that you've seen reasonably significant DMRs in a patient?
No, I think it will depend on patient to patient, because some educated patients who come to us after doing a lot of Googling, so those patients I discuss upfront regarding TFR and choice of first generation or second generation TKI, everything upfront. But those patients who are not educated and elderly patients, TFR is not discussed on day one. So, and for young patients and fit patients, female patients who wants to go for pregnancy, so all those patients, I offer them TFR upfront, and that's why in those patients we start with second generation TKI upfront.
Right. Thank you, Dr. Sandeep, for your practice perspectives. It certainly has added to our panel discussion, and I'm actually collating all of this so that we can discuss it in consensus. Dr. Aditya, are you there?
Yes, sir.
Great, good. So, Dr. Aditya, the same set of two first opening questions for you: low so-called risk, high so-called risk. Your thoughts and what you practice before I go on to the second part.
Yeah, high SORCAL risk, everybody, I try and offer nilotinib in first line. Low SORCAL risk, it depends on the patient profile that we get. If it's a younger patient, then I am tempted to start nilotinib. But if it's an elderly patient, multiple comorbidities, then we keep it simple. We give imatinib. As to why I dasatinib in high SORCAL, a little bit of my own personal bias here. My experiences with the generic dasatinib have not been very great. I am frequently having to either dose modify or change the dose because of cytopenias with dasatinib, especially thrombocytopenia is a big issue for me. That's the reason why I have after initially trying my hands, and I know there is some data over trying to give 50 milligrams of dasatinib per day versus 100 milligrams of dasatinib per day in a upfront chronic phase CML. But given all of this, I try to keep it simple and do nilotinib in first line.
Right. Thanks for you sharing your experience, Aditya, on those choices. Coming to the second part, so do you do a baseline BCR-ABL, and subsequently how frequently do you monitor the BCR-ABL and your satisfaction with the labs on that front?
So we don't have in-house qPCR testing for BCR-ABL. We have just a FISH in-house. Having said that, the cost-wise quantitative PCR testing has come down to such a low level, especially with all the support programs and coupons that we have. It doesn't make too much of a difference to if we do qPCR upfront. So in terms of finances, so I do end up doing quantitative PCRs upfront. At least for the first 1 year, I try and do it every 3 months. Once a patient has achieved a MMR, then I give the patient a little bit of a choice, and I also relax a little bit over there. As far as the lab issues are there, so I do outsource my testing to nationalized labs. So I don't think that has to be a problem, sir.
Okay. So, and are you offering TFR, if at all? And if so, is it upfront or is it after, say, 2-3 years down the line when you're comfortable with the DMR?
I agree with I agree with our first expert here in the sense that I do discuss this at the first visit with my patient. I definitely discuss this with the first visit in my patient, especially if I feel that the patients that we have fit into the profile of a young patient, an educated, a committed patient who is aware of the choices that they have, and especially as Dr. Sandeep said, somebody who's have gone through Google before coming to a doctor. So that's a discussion I would like to have upfront, and I tell them that these are the milestones that you need to hit, and if you are hitting these milestones at this point of time in your tenure, we might try and do this.
Right. Thank you, Aditya, for your inputs. I will come back again at the end for your final comments before I go on to the others.
Thank you, sir.
Right. Our next panelist is Dr. Lalit Mohan. Dr. Lalit, are you there?
Yeah. Very good evening, and thank you so much, Dr. Sharath.
Good evening, Dr. Lalit. So again, the first same set of questions to you, Dr. Lalit, because the idea is to get experience of all our panelists on what they are actually doing. So low SOCAL risk and high SOCAL risk, if you can just give your thoughts.
So in low SOCAL risk patient, especially if the person is elderly person with comorbidity, usually imatinib is the first drug of choice. And I have full faith in imatinib, using for last more than almost 2 decades now. The other issue comes to young person who is fit and where TFR remains the target in mind whenever we make the first discussion with the patient. Even in low SOCAL risk patient, also I try to start with the second generation TKI. And of course, there the choice comes between nilotinib and dasatinib. But of course, in young fit patient pregnancy, if we plan in future, usually we start with second generation TKI, even in low SOCAL risk patient. When it comes to high SOCAL risk patient in chronic phase, of course, the choice remains between the second generation TKI, so dasatinib versus nilotinib. Previously, I have used nilotinib in good number of patients without any significant side effects, so I love to use nilotinib. But nowadays, because of the generic dasatinib available for us, and the cost is very, very low, so usually I start with the dasatinib in many of these patients with high so-called risk. Of course, there are some problems as mentioned by previous panelists with dasatinib. So usually I start with 100 milligram in CML CP. And of course, in initial few months, the monitoring remains intense and patients develop some side effect. And again, we titrate the dose based on the response and based on the platelet count and the myelosuppression and other side effects. But the second gen TKI remains the treatment of choice in high so-called risk patients. In patients who are elderly person, even with high so-called risk patient, I am always scared of the side effects. So looking to the comorbidity, again, I take a call if TFR is the target, or we can even try with imatinib also in these patients.
Okay. How frequently are you monitoring the BCR-ABL, and are you kind of happy with the reports you're getting, when you see a consistent zero value, or does that fluctuate up and down, which makes you a little jittery? A practical question.
Yeah, so very true. In fact, the monitoring with BCR-ABL, I do it baseline in all the patients along with the bone marrow cytogenetic, and subsequently, initial 1 year, I take patients that it will be very rigid protocol that every 3 monthly we will do the BCR-ABL, and we tell them initially that our target to bring down the BCR-ABL to 0 level by the end of 1 year. So most patients, they understand and they also feel happy with that. So every 3 monthly for initial 1 year, if we achieve the milestones, then we switch over from 3 months to 6 monthly, and then of course 6 months to 9 months to 1 year, also depending on the patient's age, convenience, comfort. About the lab part you asked me, most commonly we are happy with the outsourced lab, and the companies have got a co-pay coupon system. So most of my patients, almost 100% of my patients, they are getting the BCR-ABL done through that co-pay coupons, and usually we are sending it to some daily-based lab. And the other part is the lab has started during the COVID era. They have started to collect the BCR-ABL sample from their doorstep also. So that remains the advantage.
Right. Are you offering TFR to your patients? And if so, have you done it for some patients, Dr. Lalit?
Yes, of course, we do offer the TFR. So whenever I see a young patient, fit, educated person, I discuss the TFR upfront also and tell them that if you take this drug minimum for 5 years or so, and if your BCR-ABL touches to 0 and remains constantly undetectable or 0, you may be a candidate for TFR. So that remains a good, rather than previously saying to all patients that you need to continue the TKI lifetime. Now I tell them that you may be disease-free after say 5-6 years or so. So TFR discussed with almost all young patients where TFR remains the target, not in the elderly person. And I have close to 9 or 10 patients who are undergoing TFR. And generously, I tell them that each month we will do BCR-ABL, and I tell them that you mark in your calendar that each month on a fixed date you will do BCR-ABL, and we communicate either through phone or through mail, and we keep checking that BCR-ABL is well controlled. And most of these patients are in regular touch with me through phone and through various methods.
Right. Thank you, Dr. Lalit, for your inputs. Certainly very, very practical inputs there. I'll now go on to next panelist, Dr. Deepak Charles. Welcome, Deepak. I'll start again with the same set of questions. Your choice in low and high risk CP.
Thank you, sir. So, with regard to the first question in terms of low risk CP, my choice would be as a blanket statement, imatinib. But again, it depends on the patient profile, as mentioned by the previous panelist. If it is a patient whom I will be discussing my the TFR concept, then I'll be thinking of going for a second generation TKI. Otherwise, it would be imatinib. In case of high risk, high so-called CP, I would prefer a second generation TKI, but again, in elderly patients, I would still give the benefit of imatinib being much more friendly in these patients.
Right. To the second part is on the testing. How frequently are you monitoring? And are you happy with the current set of testing facilities available? Are you having to cross-check a value sometimes, occasionally, before you take that decision for TFR?
The monitoring is according to the ELN guidelines. So in the first 1 year, it will be every 3 months. I do a baseline quantitative PCR because there is some data on the kinetics of response in the first 3 months. Especially, I will think of that in high subcal risk patients to see whether their kinetics are coming down as expected or whether it's getting plateau. And with regard to the whether I'm happy with the current lab testing, we have had issues with a couple of patients whom we had to reconfirm by doing a marrow cytogenetics whether they have lost the response because we got some aberrations in the molecular response. And on repeated testing, we have found that it was not so. So we discussed with the lab team, and now we have got it corrected. So it's going smoothly for the last couple of years.
Okay. So are you bringing up the issue of TFR upfront, Deepak, or is it after seeing response for, say, 2 or 3 years?
In young patients and especially young females, we do give the option of a TFR. And currently, as one patient, just one patient who is at present 12 plus 14 months now into follow-up is maintaining his response.
Right. Thank you. Thank you, Deepak. I'll come back right at the end again for your views on the TFR part. We'll go on to Dr. Mobin. Dr. Mobin, welcome. And again, the same first 2 questions for you of your choice in low SOCAL and high SOCAL risk CP.
Sir, for low SOCAL risk, I use imatinib. High SOCAL risk, I use dasatinib or nilotinib based on the comorbidities.
Okay. What about baseline BCR-ABL, baseline cytogenetics, and the monitoring, Mobin?
I do baseline cytogenetics. I usually won't do baseline BCR-ABL levels.
Okay.
And frequency, 3 monthly, I try to firm and try to do it. Majority of the patients comply. Do very few lapses, but they tend to come and do 6 monthly. But I try to do it 3 monthly. And regarding the lab settings, as Deepak told, we had few issues, but I guess now it's all looks well, and they're reporting as highest standards. And I don't offer TFR because in our setting, I don't believe people will follow up regularly, and to maintain the close follow-up, it seems difficult in at least in my practice, but I'm sorry to differ from all other colleagues. I won't offer TFR. I never bring this discussion anytime, even at the initial visit or continuum of their care. At this point of time, I don't want to initiate that discussion also. The reason,
continue, Mobin.
The reason is, as I mentioned, I may not be able to follow them closely, or they tend to lose, follow-up. So,
yeah, the whole idea of a panel is to get everybody's views, and certainly you've given your view, which is absolutely fair. So my issue is you're certainly not offering it upfront, nor bringing it up on your own. But I think in today's world where people are kind of educated and have been Googling, so if you see somebody doing well and comes back to you on asking for that, say 3 years down the line, if he sees consistently negative BCR-ABL, what would your approach be?
I think this point of time I tend to advise them to continue care.
Okay.
As if now I'm not thought of it, or I didn't have a detailed look into that part.
Okay. Fair enough. That's clearly your thought and your practice, and that's the whole reason why we're having this discussion. So absolutely fair. So thanks, Mobin, for your inputs on that. I will next go on to Dr. Ankit. Dr. Ankit Rayani, welcome.
Dr. Sharad, Dr. Ankit Rayani is not there.
He's not there, sir. Oh, okay, fine. Then I'll just skip his questions. I will go to Dr. Vikas.
Yes, sir.
Dr. Vikas, you're here?
Yes, sir.
Yeah. So, Dr. Vikas, So same first two questions to you. Drug of choice in low SOCAL and high SOCAL risk.
So, sir, I agree with all the panelists. I think everyone has said correctly that the drug of first choice in the low SOCAL risk CP is imatinib, but only on few patients like young patient, motivated young patient, or those young female patients who are likely to get pregnant. I discussed them that you can go for the TFR, and if they are willing, then I think of starting second gen TKI. Even patient is having low risk SOCAL. And in high SOCAL risk CML-CP, I prefer second gen TKI, nilotinib or dasatinib, depending on the patient profile, comorbidities, and if the patient is elderly, I prefer imatinib, even in a high risk SOCAL, because of its safety profile.
Okay. And have you offered TFR to anybody and have you restarted in any of them so far in your practice, Dr. Vikas?
So I counsel all the potential patients who can opt for TFR. But so far I have not been able to give TFR in any of my patients because of some issues, because patient may not be motivated or patient may not want to get so much frequently testing, or maybe financial issues. So far, I am not able to do TFR in any of my patients.
Okay. And your monitoring of the BCR-ABL in the beginning is
yes,
that?
Sir, I do baseline RQ-PCR, and then as per the ELN guideline, every 3 months I do the RQ-PCR, and after the 1 year, or if the patient achieved MMR, then I ask the patient to do it every 6 months. So most of the patients rely on this. Yeah.
Right. Right. Thank you, Dr. Vikas, for your thoughts on your practice. Now, before I go on to actually the collated data, if Dr. Agarwal is there, since he also participated in my survey, sir, I'd be happy if you could take up this set of questions because I wanted your opinion also on this.
You know, the situation is totally contrast.
Right.
Practicing in Mumbai,
yes,
and practicing with private practice where a patient has to pay for everything. So only that particular patient comes to me who understands that he can afford.
Right.
So my drug, I somehow see a very skewed type of patients.
Right.
My 80% of patients are relatively young. I do not know why. So one, I have right this business of treatment-free remission on the card from day one.
Right.
The type of patients I get, even if I will not open this, they will be unsatisfied that I had a potentially curable disease and my doctor said that he will have to take medicine lifelong. And next time when he comes, he probably will lose trust in me because he got that information from a third source. And I have learned this a hard way that if you do not part with anything that exists in the literature, sooner or later patient will find it out. And he is going to ask questions that why was he not informed? I see this if you don't talk about autologous transplant in myeloma. I see this if you don't talk about daratumumab in myeloma. I see this left and right. So I think it's extremely important for a city practice like Mumbai that you reveal everything on day one to the patient. Let him choose what he can afford, what he cannot afford, what his desire is, what his desire is not there. Number one. Number two, as far as the second generation TKI, which is actually a subject of the next debate, so I don't want to talk too much. And as I wrote to you, my drug of choice is nilotinib upfront because my patients are young, they're free from cardiac events, they're free from peripheral vascular disease. I don't see this in clinical practice as a big issue. I get into BCR-ABL negativity in 75 to 80% within 6 months. And as I wrote to you, my TFR rate is extremely high. And these patients are all compliant. I think we have a little thought block when we say that money issue. A patient who can spend money on a drug for 3 months, the cost of which is more than doing a molecular, somebody already said, I don't remember the name, that the test has become so cheap. So it's a little bit of thought block that spending on testing is more expensive than continuing the drug for the lifetime and managing, doctor's fee, travel, taking leave, so many types of indirect expenses are there. So I think we have some kind of thought block. What are we left with? I answered most of your question.
Yes, the numbers, since you've treated a large number, how many you stopped and had to restart to just get a little percentage feel there?
Yeah, we had to restart in about 1/3 of the patient, which is a little less than the book picture of 50-50.
Right.
Maybe because, again, I said we've got younger patients, we're very compliant patients. Patients are on second generation TKI upfront. The main drug is nilotinib. Maybe those are some reasons why we have less number of patients who relapsed when TFR was offered.
Right. Thank you. Thank you so much for that input. So I wanted that entire spectrum, and that's what we got, and I wanted that percentage. So actually what I did was I put together a little table from all our responses from the people on this panel, and this is what it is. So like I said, most people, 75% in low risk preferred imatinib. First line drug in high risk SoCal, 100% went with the second generation. The individual pick of nilotinib and dasatinib was 25%, 37%. The rest of them said either. Are you doing baseline bone marrow with cytogenetics? 100% yes. Are you doing baseline BCR-ABL quantitative? It's a 50-50 toss-up among the panel. How frequently do you monitor? Everybody is going Q3 months, the quantitative PCR. I think availability of coupons and all that helps. Labs are various labs across the country, but I think each consultant, and that's why I brought it up, is kind of getting a little comfort zone with his lab and now able to rely it. Are you repeating bone marrow cytogenetics? No, only if there was disease progression. And I put together and compared this with another 8 practicing hematologists in Bangalore and tried to kind of compare their responses just to get a little feel for this discussion. And there again, a little higher percentage went with 87% for imatinib in the low risk. Whereas in the high risk, almost everybody again went with the second generation TKI. It was a toss-up, a little more preference for dasatinib here in Bangalore. Baseline bone marrow with cytogenetics in 75%. Some of them were not doing it. Baseline BCR-ABL 62% versus 38%. And the monitoring was kind of similar when we compared that with the panel. So are you offering TFR to your patients? So like you heard in the panel, most of them are certainly offering it. And sometimes, you know, when patients already know you kind of have to offer it, you better offer it. Only I think one person said no. If yes, when are you offering it? People have their criteria of DMR or CMR at various time points. If no, will you offer it to the patient request for it? Then certainly everybody says yes. So I put together the patients handled by the panels here, and a significant number also came from Professor Agarwal. And just to get a feel of the percentage in our own country, you had about 240 patients out of the 1,600 I could kind of collate in this survey, and which is about 14% were stopped the TKI. Of these, 36% had to be restarted. So that's a ballpark number I have for data from our own country. This is just a survey collated data. And would you ever attempt a second TFR from the panel? 85% said no. Possibly 1% said we could still give it a shot at having a second shot at TFR. Now, comparing this with the 8 hematologists from Bangalore, are you offering TFR to your patients? 62% said yes. There's still about close to 40% who are not offering it. The ones who are offering it, again, are looking at responses either at 3 years or 5 years and then taking that call. Obviously, they want to be a little surer before you take it off. If you were not offering it initially and then the patient then requested, are you then offering? 100% are saying yes. Here, when we just collated the numbers handled by these, the hematologists, there are about 355 odd patients. 5% of them, they could stop the TKI. And among the ones stopped, about 42% had to be restarted. So it's a little higher number. It's kind of all averaging in that 40% range where you had to kind of restart. Would you ever attempt a second TFR? Most of them said no. So this is what is the gist from all the data collated from the panelists and from some of the members from here. We're just running bang on time for another 2-3 minutes of, I think, final comments from the panelists. So I will just quickly give it to the panel one by one. If you can just tell me, how do you think, is it practical to offer TFR in our country with our availability of the generics and the monitoring techniques which are there and the knowledge the patients have? Do you think it's practical, and would you kind of offer it to your patients? So let's quickly run it in the same order, starting with Ramaswamy. Just a one-liner answer, and then we'll keep moving.
Yeah, maybe feasible in the future. At this point, it is difficult.
Okay. Sandeep, if you're there, I think he's left here to leave in a hurry. Aditya?
Yes, I am offering. I have a fairly well-educated population to treat, and I am offering to everyone.
And you think it's practical in our country?
Yes, yes, sir.
Okay.
At least in the settings that I am treating.
Okay. Dr. Charles?
Yes, sir. Of course, it is practical, and whoever is counseled and educated can be attempted for that.
Right. Dr. Mobin, you're the firm believer of no, so I should hear it from you.
This point of time, I still continue. I mean, I won't offer TFR. Maybe a mature data or more practical data coming from India. I may change my thoughts in the future.
Right. Okay, fair enough. Dr. Lalit?
I think this is feasible in India. This is practical in India, and this is most cost-effective way. Dr. Agarwal has already highlighted the indirect cost involved. So I think we all should attempt for TFR in CML in degenerate patient.
Right. Dr. Vikas, one final comment.
Yeah, it is difficult, but possible. There are some issues like affordability and repeated blood testing, but in highly motivated patient, it is possible.
Okay, right. One final comment from Dr. Agarwal, and then we close this session. Sir.
As I said, I'm an odd man out. I firmly believe that any patient, when you give him the lollipop, that the treatment can be stopped. Why will he not like to stop? Continuing the treatment has 100 type of indirect inconveniences, expenses, toxicities. So I think it is the way you counsel the patient. The patient has to be counselable. I agree. I mean, you have different set of patients, as we just heard from Dr. Mobin, and what I'm talking is absolutely contrast. So if you have a type of patient who can be counseled, where the family gets involved, the friends get involved, the patient is deeply involved, the younger lot, they are worried about the future. Who doesn't want to get rid of the disease and the treatment? There won't be even one person. So it's just probably the type of patient you have and the type of approach you have. Thank you.
Right. Thank you, sir. I think we'll end on that note. It's certainly a practical thing in our country, and I think, reasonably discussed it lengthwise. Thank you.
Thank you, Professor Sharad. That was wonderful. I mean, very few people take so much interest and pain in planning a panel discussion. I haven't seen something like what you have done today. Hats off to you for the efforts you have put in, and hats off to your panelists. We go on to the third part. So those of you who have tuned late, the idea of this particular 5 days webinar was conceived by Dr. Reddy's, and they offered Mumbai Hematology Group to execute it, and we did it. It was called Year in Review Hematology 2021 for a simple reason that the contents are basically containing what has been published or presented in the current academic year or the calendar year between January and October of 2021. From the house of Dr. Reddy's, as far as CML is concerned, you have this wonderful molecule dasatinib in various strands 50, 70, and 100 under the name Invista. We go to the third part of today's webinar, and that's a debate. And debate is always very, very exciting. And this is a part of where we just discuss something. To use 2G TKI upfront should be the standard of care. In favor is Dr. Hari Menon. He is hemato-oncologist, medical oncologist, BMT physician, Cytopenia Cancer Hospital, Bangalore. And against the motion is Dr. Abhay Bhave, consultant hematologist, Lilavati Hospital, Mumbai. So we begin with Dr. Hari, please.
Thank you, sir, and good evening to you, and thank you for having me here. I'll just share my screen. Is my screen visible, sir?
Not yet.
Yes?
Now, yes.
Yes, thank you, sir. Thank you.
Make it slideshow.
Yes, sir. Thank you, sir. So I just made a little modification using second generation TKIs upfront in CML, the standard of care. And it's a debate, and I will eagerly await my colleagues' rebuttal on this. But Usually, when I had my last debate, I will confess that I was debating against the motion, but it's always interesting to do something and introspect into what the data has to say. And today I will talk about why second-generation TKIs have to be used in frontline CML settings. So before doing that, what do we know about CML outcomes in the era of TKIs? And this is a very favored graph, and this is a German CML study group since 1983, and we will appreciate that the survival has dramatically improved, something we don't encounter so frequently in oncology practice and hematological practice. And this is what we see in the graph with a 10-year survival of almost 83% related to all-cause mortality in patients with CML. And if you look at the 8-year probability, it's almost 96% if you take out many of the outcomes that is non-CML related mortality in these patients. And this is the popular 10-year survival data on TKIs, which is published in the New England Journal, which clearly demonstrated a survival of close to 90%, 92% in these patients at the 10-year time point. We also have this large study from the CML4 study group, which clearly demonstrated a relative, they looked at the relative and overall survival in close to 1,536 patients and clearly demonstrated there was an improvement in the survival in these patients in CML, and more so when you looked at the relative survival at 10 year, it was 92%. When you look at the observed survival at 10 year, it is 82%. That included other non-CML related mortality too. We also know from the IRIS-8 study that we do encounter accelerated phase and progression to accelerated phase and blast crisis, even in patients on TKI, but we also recognize that most of these occur in the first 3 years, though there was a bump that was seen later on in the 7th and the 8th year for reasons unexplained, maybe association with acquisition of mutations, but most of the events that happen are usually in the first 3 years. And we also understand that in the TKI era, there is a recognition that early responses translates into better event-free survival and overall survival. And this was from the IRIS study. And this has further been documented in multiple studies, which has clearly demonstrated, irrespective of what is the kind of drug that we use, whether it is a first generation, which is imatinib, or the second generation TKIs, be it itacitinib or nilotinib, there is clearly a demonstration of long-term survival in patients who achieve an early responses, which is popularized at the time as a figure of 10% or less of BCR-ABL transcripts at the end of 3 months. And this has been clearly demonstrated across all studies that have been done, which included first and second generation TKIs, and more achieved when dealing with second generation tyrosine kinase inhibitors. The final aspect, which was the topic of discussion in the previous panel, was can we achieve treatment-free remissions wherein we can get off the drug with patients on TKIs, and this is the popular, which triggered several other studies looking into the prospect of relapse-free or treatment-free survival in CML patients. And we know that there has been some improvement over what was the landmark study, which is a STIM study, which had a 24-month treatment-free remission rates of almost 40% when patients were taken off therapy after sustaining a response for more than 5 years in terms of complete molecular responses in these patients. And this has been again reproduced in many other studies, including the second generation TKIs. So we know that imatinib in CML, the long-term results with frontline imatinib in CML demonstrate a continued success. And it's about 91%, close to 92% complete cytogenetic responses at 10 years and 93% major molecular responses. And an MR 4.5, which is being a bit more discerning of about 63%. And we also recognize that as compared to not as compared to the second generation, but as compared to the earlier treatments, there is a lower risk of transformation, and the 10-year event-free survival is about 78, close to 80%. But what we must understand is that there is a scope to improve outcomes whenever possible, and it becomes imperative when the outcomes are not good, that we do encounter in patients with CML. And also it is desirable when a good outcome can be made better. And this has fortunately been the path in which the CML therapy has moved forward in the past several years. So can we do better for CML with second generation TKIs is a question over here. The arguments are purely based on surrogate markers, and this has certainly matured over the last 5 years. And is it enough to beat the long-term data for imatinib? I would say certainly. And if you look at the long-term benefits and risk of frontline nilotinib versus imatinib for chronic myeloid leukemia, the 5-year update of the NS10D study, we do recognize that the early responses at 1 year is distinctly superior, almost double the responses that we see as against imatinib, which is more importantly sustained over a period of time. And that difference is maintained even at the end of 5 years. And we do understand that even at the close to the 10-year time point of NS10D study, we see this separation lasting as we go down the line. And if you look at the MR4 and the MR 4.5, also there is a distinct difference as compared to what imatinib can achieve over the same time points. But disappointingly, we do understand that there is not such a significant difference as far as the progression-free survival and the overall survival is concerned when compared to imatinib. Now, and we also note similar results from the Decision study, which is the other second-generation TKIs, pretty much mirroring what we see in the NS10D study, and again showing a close to a 12% difference at the time point, at the 5-year time point. And we do understand that the time with patients achieving MR 4.5 is also close to 9% better for the Decision study, for the dasatinib study. So that is similar to what we see with the bosutinib, which is the other third generation TKI, wherein we do encounter, as is true with nilotinib and dasatinib, a similar higher degree of major molecular response, MR4 and MR 4.5, which is distinctly superior for the second generation TKI. But so what do we understand? The lack of survival benefit with second generation TKI. Why do we encounter that? It is a disappointment, no doubt, but it is unrealistic to expect a survival benefit, particularly with the short-term follow-up that is available. The IRIS trial, despite the vast difference in complete cytogenetic response between imatinib and interferon, took 10 years to demonstrate a survival benefit, which was very modest, 83 versus 78%. But we must understand that this was also contributed by the early crossover that was encountered in the study, wherein patients on the interferon arm moved on to the, in the cytarabine with the interferon arm moved on to to imatinib. Also, the achievement of the complete cytogenetic response has a survival benefit, and this reaches relative survival similar to the general population, and the cumulative cytogenetic response, which is fairly large. We do understand that complete cytogenetic response rates is a good surrogate marker for long-term survival. And this was achieved with imatinib close to 77%. And if you look at the interferon data too, those patients who achieved a complete cytogenetic response were those who were long-term survivors. So the 10-year event-free survival with imatinib in IRIS might be overestimated, is what I would say, because the patients were censored early. And other studies have reported, again, a modest second, actually, in terms of 5-year event-free survival of as low as 63 to 71%, as against what we saw in the IRIS study, which was close to 84 to 91%. So the need to use second generation TKIs up front, survival has neared, but the general population, therefore, other endpoints of greater value is required to be looked into. So the early responses are important and constitute part of the definition of optimal responses. And the BCR-ABL transcript levels of 10% at 3 months, 1% at 6 months correlate definitely with event-free survival. And this difference in long-term outcomes between those with or without such responses is relatively small but consistent across all multiple reports. And the outcome is similar, whether the response is achieved with imatinib or with second-generation TKI. So the bottom line is that early responses are achieved consistently and significantly more frequently with second-generation TKI to the tune of 85 to 90% as against imatinib, which is only around 65%. So achieving deep molecular responses is also an important target as far as CML therapy goes. And we do recognize that DMR today is more relevant endpoint for most patients. And this suggestion has to achieve a DMR may eventually have a survival benefit. And this is what has been published in the Lancet Hematology by Sasaka et al., which looked into those patients in terms of their outcomes and achieving deep molecular responses. And those patients who achieved MR 4.5 had a better outcome. Similarly, the strongest and most controversial benefit for a DMR is the ability for the patient to get onto a platform of treatment-free treatment discontinuation or treatment-free remission strategy. So if you look at this table, irrespective of what the second-generation TKIs were, so the achievement of early molecular response, the achievement of MR 4.5, the achievement of major molecular response, and the achievement of, and the decline in the number of patients who actually transformed into accelerated phase of blast crisis were definitely favoring the second-generation TKIs, irrespective of what is the kind of second generation that was used. And similarly, the cumulative, but we do understand that these are also achieved with imatinib, but you must understand that this occurs over a long time point. What we encounter as the final endpoints is at the end of 9 years or close to 10 years for imatinib. The confirmed MR 4.5 is only 54%. And the MR 4.5 that was reached more quickly with optimized was always achieved with the high dose imatinib, which is clearly demonstrated by the CML4 study by the German group. And the high doses of imatinib and early molecular response predicted MR 4.5. This was also clearly demonstrated in the CML4 study. And there were no patients with confirmed had experienced any progression. So even the CML4 study with a higher dose of imatinib demonstrated that achievement of a deep molecular response, which is what is achieved with a second generation TKI, translates into better outcomes for such patients. And this was a meta-analysis which clearly demonstrated a favor towards a second generation TKI, whether across 5 important studies, and clearly the second generation had a was better in terms of achieving complete cytogenetic response, achieving progression-free accelerated fat or blast crisis, achieving MMR, and also not so much in terms of acquisition of mutations, though there are some concerns that there might be some acquisitions of unique mutations when patients are on dasatinib, though the larger studies have not shown any great correlation. What about toxicity of second generation TKI? The safety profile of all TKIs are favorable, but they do have unique toxicities which we have to recognize. And these events have mostly been among patients with additional risk factors, patients with hypertension, diabetes, and hyperglycemia. And many of these have resulted in a toxicity profile like veno-occlusive diseases or arterial thrombosis in patients, especially on nilotinib, or for that matter with underlying lung problem or cardiac issues or lung problems with dasatinib in terms of pleural effusion, though we do understand that pleural effusion is many a time an idiosyncratic response to imatinib. So, however, an overall assessment of adverse events in randomized studies for the second generation TKIs showed that the toxicity was probably overestimated in the TKIs, though there are unique toxicities. And if we were discerning in using the TKIs in such patients, we are less encountered to have these problems. And the possibility of the target of shortening the overall exposure of TKIs by obtaining faster and quicker responses and achieving the target of MR4 and 4.5 leads to a successful treatment discontinuation strategy. So in conclusion, I would say that the use of second generation TKIs as first-line therapy is certainly an appropriate approach because it induces early responses, which we now know today that over a period of time translates into getting the patient onto a platform wherein we can explore treatment-free remission, which is a robust endpoint that we need to look at. It induces sustained early cytogenetic and molecular responses, achieves early deeper molecular responses consistently, and definitely a platform for pushing greater numbers into TFR. It is unique, but manageable toxicity can be obviated when used discerningly, and it decreases transformation rates. There is no survival benefit, I would agree. However, the surrogate endpoints are certainly solidifying better to give credibility to the thought that, and on the long run, this may also show a difference. So with that, I conclude. Thank you.
Thank you so much, Hari. So we now move to Dr. Abhay Bhave. And in case we are not left with any time, we will not have the rebuttal. Okay, Abhay.
Thank you, sir. I just hope I can share my slides. I hope my slide is visible and
yes.
I can be heard.
Yes.
Thank you very much. First of all, thank you very much for the opportunity, Dr. Agarwal. And Hari, I mean, it's a hard act to follow, mate. But I'm giving this job, so I'm doing it. You know, I think I misunderstood the debate. The debate is CML, I'm assuming CP. To use 2G TKI upfront should be the standard of care. That means every person who walks into your clinic will get the 2G. Now that's where I want to debate. I'm not saying anything about imatinib versus second generation. It's not an issue. We know the score. But every person who walks into your clinic, you want to give 2G? I'm a little bit worried about that. So my answer is yet, hang on, imatinib still might be a way to go. So just to give you some home truths on what I think, in India, imatinib, nilotinib, dasatinib are available for frontline treatment. There's a problem of too many escalations. Now have to make a difficult choice. All three available TKIs have shown a survival advantage, and they all represent reasonable choices. However, in individual patients, the case may be stronger for a particular TKI. Now, this is my nice face comments. Then comes Hari saying that he wants to use 2G TKI upfront as a standard of care for any person who walks into the clinic. Now that makes me angry. I said, how is that going to happen? So I have to think differently. You've forgotten a hero. You've forgotten imatinib. Imatinib has done human service. When you and I were studying, we were doing transplants for CML, and you and I both know what had happened to our patients. Came along imatinib, mesylate, things changed. People started taking tablets and started surviving a bad disease. And they did better. Even when patients had to take interferon, they had problems, and imatinib was even better than that. We shouldn't forget our heroes. So let me tell you about the journey of this drug and its travails in a disease, that the competition it has to face, the comparison that it goes through, and the commotion that pharmas do in order to say my drug is better than yours. So we've got a disease which has got a gene library. You identify a target in it, and then you get something called as CAN, Candidate Alert Notice. You may have 3 or 4 candidates, but then you'll probably find 1 or 2 of them which will go through phase 1, 2, 3 trials. And then from that, you'll derive the response rates, progression-free survival, disease-free survival, overall survival. And I think imatinib mesylate did a great job. And beautifully, Hari has already told you about how good imatinib mesylate has been as a treatment process in CML. And then he says 2G TKI is fast and furious. It works rapidly in order to bring down the disease process. I agree, but where's the overall survival? And Hari, I'm nobody in CML, but this has been told by the ELN panel in 2020 last year, that yes, 2G TKIs are great drugs, but overall survival, that's a different matter. And then you put out an olive branch saying, let's do TFR. That means you withdraw the drug and you give them a normal survival, like the normal population, with a good quality of life. This is what you want to offer, which is why you want to start the second generation TKI. Then you also say that about 45% of CML patients in CP will not achieve a desired response with imatinib mesylate. I'll contest that. Now, in all films, there is a small song and dance sequence. There's a little bit of melancholic sound and music at the background. So I'm going to tell you, look, we are not a poor country, but we are actually a rich one because imatinib mesylate is available at an affordable rate to each and every citizen of the country. Any person in this country who has CML CP will and can be treated with imatinib mesylate, which means if we can do that, and why are we putting down imatinib? There are people who do very well on it. You and me both have patients. They can live as long and as well as a person who does not have CML, provided they respond very well. Now we got new drugs, the 2Gs, and Hari has mentioned all of them. These drugs have come to the market, but at what cost? Now, I want to tell the audience, not cost of money, cost of side effects. There's something called as fragility index. That means for the number needed to treat, they have been treated well, but at what side effects? Number needed to harm, that yes, people got treated, but what was the harm that occurred to them? No one talks about the fragility index. It's quite high in the 2G. So the side effects are something that we have to keep in mind. Don't forget, many of your patients of CML incidentally diagnosed coming to the clinic. They're otherwise very well, and they can't believe they've got cancer. Then you treat them and you give them side effects, and they suddenly become patients. How does that work? Doesn't make sense. And then we speak about health-related quality of life. If you have to give them health-related quality of life, let us give them a drug which has least side effects. And I can't think of anything more than imatinib mesylate. You're probably wondering, what is that HOYH? Well, that's a short form for hand on your heart. Keep a hand on your heart. Although deep molecular responses occurred more rapidly with 2G TKIs, this does not translate into overall survival as compared to imatinib at a standard dose of 400. And this 400 was compared with 600, 800, interferon combinations, cytarabine. Nothing did as well, or all were comparable to imatinib 400. Now, don't take off that hand from your heart. How many people in your practice wants to stop imatinib mesylate? Genuinely not many, because there's so less side effects. They're scared to stop the drug. They're wondering, if I'm one of those 60% where the disease comes back, will I respond again? I have to do that monthly test. Cost may have come down, but they still have to do a test, and many people still cannot handle the cost. So it's not that easy a decision to take. And then TFR is also available with imatinib mesylate, and the STIM, which beautifully Hari has shown you, we've got beautiful TFRs, and we can also stop imatinib mesylate. So you win-win, less side effects, less cost, and TFR. What more do you want? Again, HOYH has come up, hand on your heart. Now, I'm not going to say this loudly because Hari may not like it. Just look at the side effects. You can read it for yourself. Nilotinib, dasatinib, and look at imatinib. Tell me, what do you feel? Don't say it loud. Hari might not like it. But the side effects of imatinib are very few, very manageable, only initially. In fact, nilotinib and dasatinib, you might get side effects coming on later on. So they might be ecstatic in the beginning, fast and furious, drop in RT-PCR, but then what? You land up with hyperglycemia, diseases affecting some organs, and then they suddenly start feeling, oh my God, now I'm actually a patient. So you have to think carefully and select properly. Let me introduce you to Sustainem. This is a sustained TFR response or emission in imatinib mesylate. Read paragraph number 2. They have said clearly that the potentially more serious side effects of 2G-KI and the increased costs and absent information about the number of patients who might actually benefit is very important. So we are going to allow more patients to get exposed to side effects of the second generation TKI, and we may not get as much benefit or successful TFR in all of them. So the ENL panel, again, not me, I'm nobody in CML, but ENL panel said it does not recommend a first-line 2G TKI or a change to 2G TKI for a faster DMR. But yes, it agrees that a certain cohort of patients might want to do it. Should I put a nail in the coffin? Well, MMR is a great way to look at things. If you get an MMR in CML, you're sorted. The chance of you advancing in your disease is less than 2 per 1,000 patient years. Yes, you'll monitor the molecular marker, because there's no doubt that some people can develop resistance, as Hari has said. So you have to monitor it. I'm not saying no, you monitor it. But Hari has to give me predictive biomarkers or tools upfront to say that imatinib will not work. Why has he eliminated imatinib from the tools? My patient may not have the money, or may have the money but may not want to spend on the drug, but have other things to spend on. Let's look at their quality of life. So IRIS data presented 45% discontinued, but they didn't tell you only 16% discontinued because of a subtherapeutic response. 17% of the patients discontinued for other reasons. And there were other reasons for not responding, which is common to all drugs which are in CML. Estimated overall survival 8 years was 85%, 93 considering only CML related deaths. Progression on imatinib mesylate drops from 2 to 3% in the first 2 to 3 years to rare after this. Freedom from progression to accelerated phase of blast crisis is 92%. We are fighting for that 8%. You want to give 2G for that 8% so that you don't have this problem, which means you're making 90 odd people take a second generation without there being a reason. A bit unfair, I thought. If you counsel a patient and tell them that take imatinib on time every single day, maintain compliance, you'll still win. And look at this data. Okay, this data is only of imatinib. A progression-free survival is 83 to 94%. And the overall survival is 83 to 97% amongst all the data that has been compiled over here. And safety, no serious long-term side effects, just a little bit of effect on the heart maybe, keep a watch on 2D echo, little bit of effect on the kidney, keep a watch on EGFR, but really nothing that prevents them from having a problem. And can you reduce the dose of nilotinib from 300 BD to lesser? If the patient has done well, I can do that in imatinib. 400, I can make it 300. Even the 300 data is great. So you're giving lesser dose, probably lesser toxicity, and still getting the benefit. What's wrong with it? And I see no other organ toxicity. I don't see diabetes, heart ailment, peripheral vascular disease, hypercholesterolemia, nothing at all. Please put a hand on your heart. How many times has a imatinib mesylate patient called you up for a problem? And how many times has a 2G TKI called you? How many times have they come to the OPD to have a problem and to discuss with them? How many times have we called the imatinib guys? Once in 3 months, once in 6 months? Sometimes they just keep doing things on their own. Follow-up with imatinib of 14 years is there compared to any other agent. A great track record of imatinib mesylate. Let's put again your hand on your heart and let's put another nail into the coffin. So if you achieve MMR and we are told that you need to get it fast, imatinib mesylate may be slower, but it is slow and steady rise. You can get imatinib mesylate giving us MMR as time goes along. And it's not been bad for the patients. They are not accelerated to a accelerated phase of blast crisis. If you have achieved an MMR at 12 months, you're sorted, your chance of progression is very less. Why don't you give them a chance? It's a cheaper drug. Everyone in the panel was worried about costing, side effects. So why not give imatinib a chance? Look at this, comparing all of them. Look at the last column for the sake of time. Just look at the MMR. Yes, numerically it looks less for imatinib, but as time goes along, it picks up in each and every trial. So it's not that you need fast and furious. Sometimes we need something steady while people understand the finances better. TIDAL was a therapeutic intensification in de novo leukemia. I've underlined in this cohort 1 and cohort 2 that if you were to use a higher dose, which I'm not advocating, but if you use a higher dose like 800 milligram versus nilotinib, cohort 1 was 800, cohort 2 was nilotinib, look at the MMR. There's no difference between the two cohorts, but that's for a higher dose. Unfortunately, no one thinks of using a higher dose of imatinib upfront because there are side effects. But aren't there side effects with the 2G TKI? How come you can accept the side effects of 2G TKI, but not accept the side effects of imatinib? A little bit unfair, I thought. Too much biased against imatinib mesylate. And now there is no pharma company driving imatinib mesylate. Neither is there anyone driving dasatinib. So at the end of the day, both these two being generics, it's a free for all. It's available. There are 10 companies. You can use it. At the end of 24 months, look at the confirmed MMR. In both the cohorts, no difference. Absolutely no difference. Yes, If Hari had told me ABCD1 protein levels, if I do, and if they are expressed high, imatinib is not going to work. I accept humbly, I will stop, but give me that evidence. This was an Australian paper in 2016. Nothing has come out after that, not even about OCT1. But you give me data not to use imatinib upfront, I won't use it. Definitely, I promise you. The key point that came out of this trial was using imatinib mesylate to treat CML frontline of upfront with selective switching to nilotinib leads to an excellent molecular response. That you can start with it, and then as per ELN criteria, you can change. This strategy might be preferable to a universal first-line use of more potent agents, considering efficacy, toxicity, and economic factors. I think that's clear. So my pre-conclusion dilemmas: with the approval of many countries of nilotinib, dasatinib for frontline CML, clinicians now have to make a difficult choice because they are now competing with imatinib mesylate, which is really cheap, available cheaply for our patients at a cheap rate. All three represent reasonable choices. However, in individual patients, the case may be stronger for a particular TKI. We accept that. Each TKI has its own strengths and weaknesses. Select your patient well. So detailed knowledge of the safety profile and efficacy of each TKI, the patient's comorbidities, and clarity about the therapeutic goals will assist drug selection. No doubt about that. Talk to the patient, counsel your patient, put your hand on your heart. How many of us actually have the time to talk in detail with our patients about all this? Not many, because our OPDs are busy. But then in that, if we take our time and explain to them, it will make a lot of difference. Please remember, all these trials were powered to identify a superior rate of molecular response or cytogenetics. What came out was there's no advantage on overall survival. So you can't show superiority of these. Yeah, they're fast and furious, but they're not superior in terms of overall survival. So where do I feel 2G could be, oh my God, G? This set of patients with the panel discussed. Beautiful. I love what the panel discussion. And hats off to Sharad Damodar. What a brilliant panel. Younger patients with intermediate or high-risk disease. Patients for whom TFR is a high priority. Women who want to become pregnant. High so-called score. I don't know what's the high so-called score. We've got enough data of high so-called score also doing well on imatinib mesylate. But Hari, tomorrow there might be a role reversal. A change from your 2G TKI to imatinib might be considered if you don't get a response adequately to means you're in MMR, but patient can't continue for side effects, for cost, whatever it might be. You could come down to imatinib mesylate, and we are very happy to provide the drug to you. No problem at all. I'll conclude by saying 8-year iris follow-up continue to demonstrate long-term safety and tolerability of imatinib. Treatment guidelines, recommendations do not indicate preference for any of the three tests. None of the guidelines. You talk of ESMO, ELN, NCCN, British, no one says anything about that you should not use or you should prefer 2G. No patients with documented MMR at 12 months progress to APBC on imatinib mesylate. Great toxicity profile with IM. Some side effects of second generation can come over a period of time. Those who are not diabetic can become diabetic. Those who didn't have peripheral vascular disease could develop it. Can develop hypercholesterolemia. Do you want me to go on? Pancreas, other organs? It's an advantage that imatinib has. Yes, I agree. Suboptimal responders can be there in all the drugs. But if there is, please switch. Look at the comorbidities before you decide. Lung and cardiac is very important. And if you have an older patient, all the more important. And younger patients, sure, but you don't want them to land up in trouble because of your drug. So just be careful. The lower rates of cytogenic relapses might be associated with the patient's inability to be compliant. And that's why I say, please ask them to be compliant. Tell them it's a cheap drug, you'll do very well on it with least side effects. What's wrong with that? I don't see anything wrong with that. Generic imatinib is cost-effective line of treatment in CP. I don't have to rack my brains for hidden contraindications that I have to keep asking my patients and keep assessing them time and again. And there are late responders in MMR. Have faith in imatinib mesylate. It will deliver the goods. Thank you very much for your attention.
Thank you, Dr. Bhave. You're left 2 minutes for Hari to have the rebuttal. Go ahead, Hari.
Abhay, well defended in terms of what the imatinib has to say. What I have to say is that it's imatinib, the IRIS study is certainly one of the most elegant studies that we can fall back upon. And we do understand that there is sustained ongoing responses that we achieve, and what is being achieved in terms of the endpoints of targets of almost 60% major molecular response or deep molecular response is achieved in as high as 10 years, and in an era where we are struggling with compliance issues, etc. And with young patients who are actually wanting to get off the medications, and as you rightly said, with pregnancy, patients wanting to become pregnant, etc. In those situations, certainly we are looking at shorter durations of therapy. And when 5 years ago, we were not clear about the treatment-free remission strategies as to where to put our finger on in terms of achieving those targets. But now it is clearly emerged that we can expect a certain proportion of patients, given at least 2 to 3 years of having a deep molecular response, to achieve almost about 55% of, as we've seen in the Euroski study, to reach the target of treatment-free remission. So to me, the most attractive thing as far as the second generation TKIs, not having anything to say about the efficacy of imatinib, is that we are able to likely to able to shorten the duration of treatment. And when we are able to shorten the duration of treatment, the chances of encountering complications that are related specifically to second generation TKIs are also likely to be low, though we do have idiosyncratic responses with dasatinib, etc. And certainly, when we are looking at older patients, we would still resort to using imatinib in those patients as against the second generation TKI, because there is certainly no hurry over there for us to achieve those responses. And we also consistently know, as from the CML4 study, that when we are talking about imatinib in terms of being on par with the second generation TKI, certainly their doses have to be upped. And whenever the doses are upped, there is encountering of toxicity in relation to imatinib. So these are the problems that we have and practical problems that we face. And every drug has its merits, and it is all about using things discerningly in terms of what is best for that patient, and never accept everything. But the data is there to tell us that, of course, there is probably a merit in using these drugs to achieve those endpoints. That's all.
Thank you, Hari. Thank you, Abhay.
I will get a chance.
Just to say one sentence, in a recent debate that we had internationally, the conclusion drawn was, elder the person, more the comorbidities, shorter the lifespan left, use imatinib. Younger the patient, free from comorbidities, which the young people are. Your goal remains TFR and not overall survival, and use the second generation TKI. So that kind of dichotomy was shown by those guys. So thank you very much. And we move to the last part of our today's meet. And those of you once again have logged in late because of your work. The idea of this 5 days webinar was conceived by Dr. Reddy's, executed by Mumbai Hematology Group. It's called Year in Review Hematology 2021 for a simple reason that we're discussing what happened, what has been presented and published in last 10 months only. From the house of Dr. Reddy's, we have an important molecule in the field of chronic myeloid leukemia in VISTA, which is dasatinib 50 mg, 70 mg, and 100 mg. The last segment of today's webinar is the review of papers that were published and presented during 2021 in the field of chronic myeloid leukemia. And we have got 3 presenters. And these wonderful personalities are Dr. Malikarjun Kalashetty, is consultant in clinical hematology, hemato-oncology, and transplant field from Comprehensive Cancer Center, Manipal Hospital, Bangalore. And he's going to tell us about treating CML during pregnancy. Following this will be Dr. Anusri Prabhakaran. She occupies the similar position at Dinanath Mangeshkar Hospital at Pune, and she's going to tell us about managing cytopenias of TKI, an important question that has been put up in question box today by multiple colleagues. And the last part, of course, which is very, very important, is managing cardiopulmonary toxicity of TKI by Dr. Ayaz Ahmed, who occupies this position at Rajiv Gandhi Cancer Institute and Research Center at New Delhi. So over to Dr. Malikarjun for the first talk.
Good evening, sir, and thank you for having me in this meeting. So I'm going to quickly, I think I have 10 minutes to go through this topic of treatment of CML in pregnancy. I must start by saying the disclaimer that not all of the published data that I'm going to review are in the timeframes that sir was mentioning. So I hope I'm audible and my slides are seen.
Yes.
Yes, sir. So I'm going to quickly go through few articles. So essentially, I'm going to talk about treatment of CML in pregnancy. So most of the articles, you are going to find these words that the treatment must be individualized, that the tyrosine kinase inhibitors are certainly not safe, at least in the early pregnancy, that the only modalities of therapy which are supposedly safer are leukopharis and interferon alpha. So that is the common denominator to most of these. So when I was looking at the articles published, this was the interesting article which actually said, apart from what most of the articles are saying, that there are no widely accepted guidelines on the therapeutic options of these pregnant women with CML, and that is the need of the hour indeed. So we'll go through ELN recommendations, which have been alluded to by previous speakers, and we'll only touch upon the pregnancy and parenting. So an informed communication is indeed mandatory with patient and the family, with good collaboration with obstetric colleagues is what they've said. And most of the articles again are having a consensus stating men who are on treatment for chronic myeloid leukemia with first or second generation tyrosine kinase inhibitor, there is no evident increased risk of congenital abnormalities. So men planning fatherhood do not need to discontinue treatment. The data seems to be more for imatinib and few of the second generation tyrosine kinase inhibitor. The issue is a little more complicated in women, so it must be individualized in all pregnant women who have chronic myeloid leukemia. The TKI treatment must be discontinued in the first trimester as soon as the pregnancy is confirmed. Anomaly scan must be done, and options of continuing or discontinuing treatment or continuation of pregnancy must be exhaustively discussed and debated with the patient and family. So the teratogenesis of TKI is likely to be due to off-target, most likely PDGFR inhibition during the organogenesis. So most TKIs are contraindicated throughout pregnancy. Termination of pregnancy is a consideration in more advanced phases of the disease rather than chronic phase. And most of the articles have also said that the aspirin or low molecular heparin should be used or indicated in patients with extreme thrombocytosis. And again, leukopharis and interferon are deemed to be safe throughout pregnancy. So again, in breastfeeding or lactation, the TKI therapy is contraindicated due to the presence in the breast milk. Women eligible for a trial of treatment-free remission can safely discontinue TKI in order to conceive, and they can be off treatment throughout the pregnancy. And women who lose MMR and are pregnant are likely to reach term without clinical need for restarting treatment. So there is no hurry in initiating treatment in these, is what they have said. So if you look at the NCCN guidelines, again, they say all young people who need to be initiated on TKI, we must discuss fertility preservation. Men do not need to discontinue. Women should stop TKI therapy, and close surveillance is indeed important. And lactation, one must not use TKI. So the British Society guidelines are similar to the ELN recommendations. We'll quickly go through them. So again, men need not stop TKI, and women who come with chronic phase, chronic myeloid leukemia, they go ahead and say that termination should not be advocated unless it is at the request of the patient. The management would depend on the disease burden and other parameters, including the gestation age of the patient. Often the pregnancy can continue without any intervention in patients who have low burden of the disease. Again, they say that low dose aspirin or low molecular heparin should be advised if there is extreme thrombocytosis. So there is increased risk of congenital anomalies in patients who were given imatinib or dasatinib. So most TKIs must be avoided throughout the pregnancy. If the treatment is indeed required, then perhaps leukopharis, interferon, and rarely TKIs may be considered. Leukopharis perhaps is the one with least risk to the fetus. So in a known case of, in a known CML patient who's on treatment, if they're considering pregnancy, we must try and attempt deeper molecular response before planning pregnancy. And if they become, like TFR eligible, then at least half of them can discontinue their tyrosine kinase inhibitor indefinitely. So a few studies, this is an interesting study from one of our Indian centers wherein they looked at what happened to the pregnancies. And if you were to only see the last point, 10 out of 19 pregnant patients who continued imatinib until their delivery, a majority of them had normal full-term delivery. There was one preterm, one omphalocele, and one craniosynostosis. So telling us that imatinib perhaps is safer after the organogenesis is complete. Again, a similar publication of tyrosine kinase inhibitors in pregnancy in CML. And Again, the decisions have to be individualized. All cytoreductive therapy medications must be avoided in the first trimester at least. If there is extreme leukocytosis, more than 100,000 leukapheresis might be useful. Aspirin and low molecular weight heparin must be considered in patients whose platelet count is more than 600,000. Interferon can be used, though it may have slow kinetic of response in these patients, but it is safer. In second and third trimester, they say the risk is much less since organogenesis is complete. Treatment may not be necessary if patient have low burden of the disease. Interferon can be used safely, but they kind of make a comment stating in theory imatinib can be introduced after 15 weeks of pregnancy, but the manufacturer does not recommend the same. For patients who are in axial phase of blast crisis, termination should be discussed more seriously with the pregnant lady. In patients who are already receiving treatment of CML but have received for less than 3 years, therapy must be stopped once the pregnancy is confirmed. One must consider interferon to control the disease. And a second generation TKI, they have actually said imatinib or nilotinib might be safer as against dasatinib, which must not be used at all throughout the pregnancy. So if the patient has been on the long-term treatment and having sustained MMR but not deep molecular response, alternative stopping. So if patient is planning pregnancy, they say we may not stop the medication before conception because we do not know the time frame, but it might be a good idea to stop it once the pregnancy is confirmed. But if the patient is having a deeper molecular response, MR4 or better for at least 1 to 2 years, then we can treat them like we would a patient for treatment-free remission. So those candidates who are candidates for treatment-free remission are best suited for interrupting treatment for pregnancy, and at least half of them can be off treatment indefinitely. So again, when patients are planning pregnancy or on treatment, caution must be exercised in asking them to stop before conception because of the uncertainty. And it might be a good idea to stop after confirmation of the pregnancy is what they have recommended. So if I have to summarize, for men who are planning fatherhood, they need not worry and they need not discontinue the treatment. For women, it's a little more complicated. TCAS must be stopped once the pregnancy is confirmed. Some thromboprophylaxis needed if patients have significant thrombocytosis. Interferon leukapheresis are considered safer, and most of the published articles recommend their usage. Imatinib or nilotinib might be used in select cases after organogenesis, but after clear discussion regarding the risk and benefit. Pregnancy in patients who are TFR candidates might be the easiest one where therapy can be interrupted, but we must remember to make individual decision in this scenario. I would stop there and hand it back to Dr. MBSF. Thank you for the opportunity.
Thank you, Dr. Mallikarjun. Beautifully covered the subject. Any questions from the panelists around? From the audience, I don't have a question. Anusri, you want to ask?
No, sir.
No, okay. So thank you, Dr. Mallikarjun. So we move to the second talk, and that is by Dr. Anusri Prabhakar. Go ahead.
Are you able to see my slides?
Not yet. Yes.
Yes. Good evening, all of you. At the outset, I would like to thank Dr. M.B. Agarwal for giving me this opportunity. I have been given the
slideshow mode.
Hello?
Slideshow mode. Yeah, go ahead.
I have been given the responsibility of discussing TKI-induced cytopenia. I have a disclosure to make. I have been asked to discuss the papers in 2021. I couldn't get any. So I have compiled data from 2009 to 2021, and I'll be making it a short review of this particular topic. And I have to acknowledge Dr. Arihan Jain, who helped me out with the literature review. So we'll go with these headings. So this particular short review is based on 20 company and 10 investigator-sponsored studies, which included around 8,400 patients. So if we look at the incidence of all toxicity, it varies from 2 to 90%, which is very difficult to interpret, and it is sometimes meaningless. So we'll focus on grade 3 and grade 4 cytopenias. So So what is grade 3 cytopenia? That is when hemoglobin is between 6.5 to 8 grams, absolute neutrophil count between 500 to 1000, and platelet count between 10,000 to 50,000. And what is grade 4 cytopenia? That is hemoglobin less than 6.5, ANC less than 500, and platelet count less than 10,000. So if you look at the trial data, and if you compile everything into an Excel sheet, this is what you can see. At a dose of 400 milligram per day, imatinib in chronic phase, these patients may have a maximum of neutropenia in 20% of the patients, which increases to by threefold in accelerated phase, around 60% in blast crisis. Thrombocytopenia is reported slightly lesser extent, 10%, which increases four times in AP and 6 times in blast crisis. Anemia, 7% in chronic phase, 4 times and 5 times in AP and blast crisis, respectively. Dasatinib at a dose of 100 milligram per day, all the toxicity is slightly higher compared to imatinib. Neutropenia of 35%, which increases up to 80% in blast crisis. Thrombocytopenia of 23% in chronic phase, which increases up to 85% in blast crisis. And anemia of 13%, which increases to 75% in blast crisis. This could be because of disease per se as well, not only drug-induced. With nilotinib of 800 milligram per day, incidence is slightly less compared to dasatinib. And cytopenia is more with dasatinib and nilotinib when used as a second-line TKI rather than as a first-line TKI. So if we analyze all this data together, you will come to know that neutropenia is the most common cytopenia, followed by thrombocytopenia, and anemia is the least common. And cytopenia worsens as the disease progresses, and it is more with dasatinib 100 milligram per day. And the number will be quite less when dasatinib is used at 50 milligram per day. And it is more when these drugs are used as second line rather than first line. Dasatinib per se has more toxicity because of specific inhibitory effect on platelets, which can result in dose interruption in up to 60% of patients. And if somebody requires more than 2 weeks for normalization of counts, dose reduction is recommended. If we look at other TKIs, with ponatinib, when used as third line agent, anemia is up to 6%, thrombocytopenia of 30%, and neutropenia of 17%. And bosutinib usually have lower rates of cytopenia compared to imatinib. What is the consequence? Infections and bleeding. Infection, which can result in death, is up to the tune of 0.4% in imatinib and 1.9% with dasatinib. And with bleeding, any grade of bleeding may be seen up to 20% in patients with imatinib and 25% with the dasatinib. And that resulting in death is 0.4% and 0.9% respectively. Dasatinib has inhibitory effects on neutrophils, and TKIs can produce platelet dysfunction as well, apart from thrombocytopenia. So what causes this cytopenia? It's not very clear. Two mechanisms, two hypotheses are there. One is off-target effect, that is inhibition of other kinases, PDGF, etc. To give you an overview, these are the different pathways which can get inhibited while on TKIs, and the broadest spectrum is with dasatinib. And the second hypothesis is that when CML cells infiltrate the marrow, especially in high-risk cases and patients who have advanced disease, there is reduced reserve of normal pH negative cells. So when we give TKI, the marrow becomes empty, and it takes time for repopulation of the marrow, which results in cytopenia. So we have to detect it early by doing weekly CBC till the patient achieves complete hematological response, and once in 2 weeks to a month for 3 months, and once in 3 months thereafter. So if it is a low-risk CML, we can go for conservative management. If high-risk CML, more aggressive management is required. Grade 1 and grade 2 toxicity usually does not require dose modification. Grade 3 and 4, we have to stop the drug, wait for count recovery, and restart at a lower dose and escalate to a target dose. And if there is recurrent grade 3 or 4 cytopenia, it's better to switch to another TKI. How do we do that? In chronic phase, the cutoff for stopping the drug is absolute neutrophil count less than 1,000 and platelet count less than 50,000. And if we restart it once ANC recovers back to more than 1,500 and platelet more than 75,000. And in accelerated phase and blast crisis, the cutoffs are lower, ANC less than 500 and platelet less than 10,000, we'll have to stop the drug. and restart it when the ANC is more than 500 and platelet count is more than 20,000. Numbers are the same for dasatinib and nilotinib. If the maximum dose tolerated is less than 300 for imatinib per day, less than 50 for dasatinib per day, and less than 400 for nilotinib per day, it's better to switch to another TKI. For supportive care, if there is anemia, of course, we have to rule out nutritional causes and hemolysis. If there is neutropenia with less than 500 ANC, we can use GCS support. What about thrombocytopenia? Traditionally, recombinant interleukin 11 was used. However, because of allergic reactions and arrhythmia, it's not popular now. What about TPO agonists? The effect of eltrombopag was in TKI-induced cytopenia was studied in CML patients and myelofibrosis by MD Anderson group and was published in Hematology in 2020. CML and PMF patients of TKI-induced cytopenia, where eltrombopag 50 to 300 milligram per day was given in patients more than 18 years who were on approved TKI with a platelet count less than 50,000 after 3 months of therapy. Patients who had initial cytopenia were not included in this particular study. The starting dose was 50 milligram. 2 weekly dose escalation was given till consistent platelet improvement was noted, and dose reduction was done if platelet is more than 2 lakh, and it was stopped when the platelet is more than 4 lakhs, or if there is no response in 8 weeks time. LFT was monitored once in 2 weeks and stopped if more than 3 times the upper limit of normal, and rechecked in 3 to 5 days and resumed with 25 milligram lower dose. Target platelet count attempted was more than 50,000 consistently. So what did they see? Out of this was a small study. It was an open label phase 2 study. 15 patients totally. Out of them, you can see 14 patients had meaningful response, even while on TKI, which was second line, third line, fourth line, or even fifth line. So what was the result actually? Patients who had none or minor or partial cytogenetic response, 9 of them could achieve partial or complete response. And the median percentage of TKI dose of compared to the standard dose was 55% of the standard dose before eltrombopag, and it could improve to nearly 75% of the standard dose while on eltrombopag. So with a median duration of 18 months, 12 of the 15 patients responded with a median peak platelet count of 1.5 lakhs. Median time for best response was 6 months, and 10 of the 15 patients had platelet response which is sustained for 45 months even after stopping the drug. So this was regarding that particular study. I will mention 2 more studies. This is just a case report from China of 2 patients of high-risk CML CP on diagnosis who had grade 3 to 4 cytopenia while on TKI, but the pancytopenia recovered completely on discontinuation with frank disease relapse. Even on switching the TKI, even after bone marrow transplant, the disease progressed. Eltrombopag had given partial response in one of the patients. Such events may provoke the thought that recurrent severe pancytopenia may have something to do with disease nature as well, not only the result of TKI alone. Sometimes imatinib can produce cytopenia because of marrow fibrosis. This shows extensive marrow fibrosis following imatinib, which had completely recovered on second generation TKI, nilotinib. So to conclude, cytopenia with TKI is usually in the first 4 to 6 weeks, usually grade 1 to 2. It is usually dose related and reversible and affects all cell lines to varying degrees. And grade 3 and 4 cytopenias are usually seen in the first 3 months and rare later. It is usually an expression of efficacy, not toxicity. That's all from my side. Thank you.
Thank you so much, Dr. Anushree. Hard work done to prepare this talk is obvious. A subject which looks so simple, you have presented it so beautifully. A couple of questions for you in the question box. One question is that if a particular TKI is producing grade 3 or 4 cytopenia, can you easily use the other TKIs, or even they will be dangerous?
Usually the side effects do not have cross reactivity, so we should try and change over to the next TKI, especially if it's a recurrent cytopenia with the same drug.
I fully agree with you. People having very, very severe grade 4 toxicity have tolerated an alternative TKI very easily, and you've been able to get through. The other question is, when you have cytopenia, how do you differentiate between drug toxicity versus progress of the disease?
I usually rely on monitoring the BCR-ABL1 transcripts.
Yes, I think circumstantial evidence and monitoring can help you. So those were the two questions in the question box. Anybody has a question from the panel here? No one has a question. They don't want to trouble you, Dr. Anusri, or you have given a talk which was complete. So they've understood everything. So thank you so much. Well, we have an unfortunate situation that our next speaker has not logged in, and we have no information whatsoever, despite making all our attempts by various routes to get to him, whether he is going to join us late, whether he's caught in some emergency, and so on. So it's a very unfortunate situation that sometimes you take a thing very, very casually. It doesn't matter to you that 300, 400 people are waiting for you. I feel very sad when somebody who has accepted a responsibility and then takes away his responsibility without informing. It's in today's era, it's very difficult to say that I could not communicate. It's impossible that you could not communicate. So anyway, that brings us to the end of the webinar today. I'm sorry that we could not teach you about the cardiopulmonary toxicity of TKI. That's for some other day. And now it's my duty to hand it over to Dr. Reddy's, Mr. Abhishek Bhalsa, to give his concluding remarks. And thank you on my behalf and on behalf of MSG to all the panelists, all the speakers, all the faculty, our chief guest, Dr. Maman Chandi, our lecturer, Dr. Hemant Malhotra, Dr. Sharad Damodar for his hard work, and the panelists, the two debaters, and these two beautiful review of the papers. So over to Abhishek. Abhishek is around or not?
Sir, just want to Dr. Abhishek is not there, sir. So you need to.
I think he must be thinking that we are going to close at 9:20. So fine. If there is no inter-discussion, anybody wants to discuss anything? We've got now plenty of time, really. So if nothing, then we consider this as a bye-bye for the day. Good night to everybody. Enjoy your dinner at your home. And let's be together tomorrow again at 6:30 p.m. Bye-bye.